Okay, let's go ahead and get started. Good morning, everyone, and welcome. I get the privilege of opening up day 2 of our 2-day meeting on bridging to a stronger healthcare system. So I'm delighted to be kicking off the eConsult Workgroup annual meeting. As many of you know, I'm Diana Camacho. I'm a senior program officer at the California Healthcare Foundation. I lead CHCF's work on telehealth. As many of you know, while I'm new to CHCF, my passion for eConsult began when I was at Kaiser Permanente, where I worked a lot with Blue Path Health and many other of the innovative eConsult leaders on the call today. It was clear to me then, and it remains clear to me today, that eConsults are a key tool to ensuring equitable access to specialty care. The pandemic has only magnified the shortcomings of our health system in providing equitable access to care. And while eConsult is only one tool in the toolbox, I think its value is clear. The value is in its ability to open up new access to specialty care that may not have existed or would have required months of waiting, potentially exacerbating a patient's health issues or worsening their quality of life. The value is in the ability for patients to get access to specialty care in a setting they feel comfortable in, from a provider they trust, who speaks their language and knows their history. The value is in breaking down the silos between primary and specialty care in an already fragmented health system so that patients get coordinated care centered around their needs. And finally, the value is demonstrated in how eConsults have been a lifeline during the pandemic by helping keep patients and providers distant and safe while ensuring less care was deferred. The list goes on and on. On the call today, all of you on the call today have helped to move us closer to realizing the value of eConsults. Through education, policy, and innovation, you have all helped make tremendous progress in the use of eConsults and the safety net. For example, while it didn't quite cross the finish line, eConsult reimbursement for primary care providers in California through SB 365 raised the prominence of eConsult and won bipartisan support. Not much can say that these days. I've also been really excited about the multi-payer collaboration I'm seeing across the country, including in the Central Valley, to advance the use of eConsults. Collaboration of payers, providers, and connected health technology will continue to be necessary to implement eConsult and tackle access to care disparities in our communities. As telehealth moves into a new era, collaboration needs to continue to be the cornerstone of our work. The eConsult Workgroup has been key to fostering this collaboration by bringing together all those with a stake in access to specialty care here in California, across the nation, and even globally. For this reason, CHCF has been a proud supporter of the eConsult Workgroup since 2017. While I know we're all disappointed not to be meeting in person again this year, the Blue Path team has put together a really wonderful day for us. I want to thank them and everyone involved in organizing today's meeting. I also want to thank the other sponsors for today's annual meeting: Anthem Blue Cross, Arista MD, Safety Net Connect, Blue Shield of California, Confer MD, Inland Empire Health Plan, Rubicon, and Wise Healthcare. I also want to encourage more of you to support the work of the eConsult Workgroup. If you find today's annual meeting valuable, or if you regularly attend the monthly virtual meetings, I encourage you to support their work or sponsor next year's annual meeting. And now I have the pleasure of handing it over to Libby Segarra with Blue Path Health. I've had the privilege of knowing Libby and working with Blue Path for many years. Their sustained leadership on telehealth has paved the way in California, nationally, and even beyond that for eConsults. And I think it's fair to say you've even gone global. So thank you to Blue Path team for steering the ship and bringing together this work group. So with gratitude, I pass it on to Libby. Thank you very much.
Thank you so much, Diana. You stole my thunder a little bit in saying I've been so glad to know you for the past few years. We appreciate your leadership and support of eConsult and its promise in terms of improving access to care. And we give special thanks to California Healthcare Foundation for the operational support that makes the eConsult work group exist. So thanks, Diana, for the kind introduction. This year, as we come out of the pandemic, we're still seeing the pandemic's impact: long wait times for visits, increased needs for behavioral and mental health support, and loss. And today's event, we really want to focus on resources to bridge this gap. Our title of our event is Bridge to a Stronger Health System. So I'll just do a quick review of today's agenda that's in front of you today. We're so pleased to have Dr. Laura Miller from CHCN to keynote and kick off our event today, with Ilda Martinez from California Healthcare Foundation. Our pandemic and disaster response panel will address how we're coming out of this past couple of years of challenges and bring some specific examples of what systems are doing to address that. We'll focus on policy, landscape, lessons learned. Diana mentioned the work that we and you have done this year to really push policy and to engage state leaders to really support and better understand eConsult. And later today, if you don't mind moving on to the next slide, we'll be focusing specifically on how we can be looking at reimbursement in different ways. So re-envisioning reimbursement. We'll have a lightning round with what we're glad to see our representatives from across the country. We'll look over the lunch hour at innovations that are improving patients' experiences and their lives. So we'll hear from many of our sponsors of the eConsult Workgroup and hear about their innovative solutions. As we wrap up the day, we'll hear from our eConsult Workgroup advisors, Paul Gibbony and Delphine Tuo, who will share examples of eConsult dashboards and how we are using data to address disparities in care. And we'll wrap up. We'll make sure to get you out of here on time. We know this is a long day. We also know that we have done this for a while now. No one is new to Zoom. So please get up and go as you please. Come back and join us when you can. So thank you so much. On to the next slide, please. We just want to review for you, for anyone who's new to the eConsult Workgroup. As Diana mentioned, we meet on a monthly basis, mostly focusing on education, best practices, most recent publications from you all, those who are getting out there and sharing the work and the data that you've gathered around eConsult. So we've done a lot this year. We're really proud of the work that we've done with you, our members. We've seen so much happen in terms of payer support across the country. We'll hear from a couple different payers about their programs that are engaging stakeholders across communities and helping providers to engage in eConsult. What we are so pleased to see happen is across the country and throughout the pandemic, expansion of eConsult programs to support the uninsured, access to eConsult for those that need it the most. We're happy to see that we've gotten some great traction this year offering continuing medical education CME courses for providers. We know that providers' time is needed to facilitate eConsult, and so we want to be able to acknowledge their commitment of time and energy through CME. I mentioned already we've seen great support, really looking, especially in California, with state level engagement in eConsult, pushing forward bills to support eConsult reimbursement that we'll talk about later today. And we've also heard from you that it's helpful to have tools to be able to better talk to patients about eConsult, patients and members. So we've provided some tools around better patient communications around eConsult too, using examples that so many of you have provided from your programs. We know a lot of work remains for 2022, and we hope to see you engage throughout next year as we work on our continuing goals or our continued work, what we need to focus on in the coming year. So many payers and providers have shared the data coming out of their programs in the past few years. We really encourage you to share these examples of how you're reporting and sharing with your states, your leadership, your policymakers on how eConsult is improving access to care in your state and across your communities. We'll continue to provide examples of how you, payers and providers, are supporting new models and new strategies to engage PCPs and their teams. So many of our examples today will show how eConsult has been a tool to be able to address the needs that have come out of the pandemic. And along with our pandemic work and so many of your providers on the groundwork in addressing COVID needs, in California especially, we've had other disasters to have to address: fire, flood, so many impacts on our clinics. So we want to be able to talk about how eConsult is providing tools to address these challenges in the coming year. Moving down our list of a good number of goals that we want to focus on next year, we've seen such great traction in managed care Medi-Cal support for eConsult. We'd love to be able to see that this is consistent across business lines, across payer business lines in support of eConsult. And last, we'll wrap up today with a real focus on how eConsult data and dashboards are addressing health disparities. And we'd love to be able to see over the next year other examples of how eConsult is improving access for patients of all backgrounds and of different needs. So I think with that, I'm going to introduce our keynote address. First of all, I'd like to bring on Hilda Martinez. I'm so pleased to have met Hilda in the past few months with her great work highlighting what's been going on around California in eConsult. So Hilda, I'm going to hand it to you to introduce today. And And also Ilda will introduce Dr. Laura Miller to begin our keynote. So thank you, Ilda, and welcome.
Thank you, Libby. Good morning, everyone. I'm excited to be here today to introduce our keynote speaker, who many of you know is a champion of innovation and who has spent her career working to improve the health and well-being of people in underserved communities. eConsult is a technological lifeline for many people, providing access to specialty care that might otherwise be delayed for months. Delay in timely access to specialty care can lead to a deterioration of medical conditions, poor outcomes for patients, and a negative impact on a community's overall health. I recently had the opportunity to write about Camarena Health Center, an FQHC in Madera, which is 30 minutes north of Fresno. Camarena is successfully utilizing eConsults to help fill gaps in healthcare services based in that rural community, where specialists are few and far between. Camarena serves a large Medi-Cal population, mostly farm laborers and monolingual Spanish speakers. Many of the health center's patients must overcome several obstacles to see a doctor. It's common for patients to live in households with no vehicle. In many cases, they often rely on public transportation, but in more remote areas of the region, public transportation is very limited. Dr. Joel Ramirez, Chief Medical Officer at the clinic, who was interviewed for the story, talks about how patients often walk to health center appointments. Transportation is just one of the many issues people face. Often they have difficulty taking time off from work or they lack childcare. These are the kinds of challenges our next speaker has worked for many years to overcome. Since the start of her career, Dr. Laura Miller has worked tirelessly to create better access to quality healthcare for all Californians. We are very fortunate to have her here today to share her experiences and insights, particularly around eConsults. As many of you already know, she is the Chief Medical Officer of the Community Health Center Network, which serves more than 140,000 managed Medi-Cal members in Alameda and Contra Costa counties. She is a primary care internist at the Lifelong Medical Care, where she has worked since 1999. Prior to CHCN, she was the Associate Medical Director at Lifelong East Oakland Clinic. In addition to the leadership that she has provided at CHCN, she has worked on many improvement initiatives and led the over 60s hospital service. Dr. Miller received her undergraduate degree from Wesleyan University, her medical degree from Harvard Medical School, and completed her internal medicine residency at the University of California, San Francisco. People describe her as brilliant, humble, and extremely dedicated. A fun fact about Dr. Miller is that she loves fiber arts, knitting, sewing, spinning, and weaving. We are excited that she is here today to kick off a day full of great sessions that will no doubt lead to much learning and to the exchange of ideas. Without further ado, I would like to hand the spotlight over to Dr. Miller.
Thank you so much, Ilda. I really appreciate the introduction and the shout out to Fiber Arts. I'm speaking, so I won't be knitting, but trust me, I knit on Zoom. I was really honored to be invited. And I think in some ways the term keynote, I always think of keynote as like an absolute expert in the field. I feel like more of a voice from the trenches, if you will, in terms of eConsult. I am indeed a passionate supporter of eConsult and really want to bring you stories from my experience and help spark conversation. There are very illustrious experts later on today, so I hope that my report from the trenches can spark conversation. So my interest actually in e-technologies started many, many years ago. Right after residency, I did 2 years of National Health Service Corps work on the Hupa Reservation in Humboldt County. I essentially left medical school with a 2-year service debt and took care of that debt on the Hupa Reservation. And that was incredibly challenging in a lot of ways. Internet was barely functioning, if at all. I think it was dial-up. There was no uptodate.com online. There was this group called physiciansonline.net, and you could enter a case and maybe somebody out there would answer you. And I lived with my Harrison's textbook, basically, to try to do care on the res. And it was, it was what I was trained for. And Harrison's worked for me. I did the best that I could. And that's what we had then. That was really 96 to 98. So fast forward to 2008, I actually did a road trip back up to Hoopa with my then 10-year-old and visited the clinic. I was like, hey, honey, let's go see Mama's old clinic. So we went, and they were so thrilled to have a retinopathy camera at the health center, at the clinic, and they would shoot retinopathy pictures to UC Davis, and we're accomplishing diabetes screening, retinopathy screening on the Hoopa Reservation, which is like an hour and a half from Eureka and 2 hours from Reading, et cetera. It was care that I couldn't have gotten 10 years prior at Hoopa, and it was care that I couldn't get from my people at Lifelong East Oakland. In the heart of Oakland, I couldn't get my patients to manage the transport, all of the complexities of getting to an ophthalmologist or an optometrist for retinal screens. And that sparked me to say, hey, wait a minute, there are tremendous lessons to be learned here. And let's see what we can do in an urban setting with these e-technologies. We partnered with UC Berkeley, Jorge Cuadros, who I'm sure is well known, and we got it going, and it's still going today. So that was really my first introduction to the power of e-consult, of asynchronous communication. Super powerful. Then fast forward again, I moved some of my time to Community Health Center Network in 2015. And a couple of folks on our staff, Rhonda Aubrey and Ella Schwartz, were talking about this cool thing called Rubicon that they were working on. And I said, hey, wait a minute, I want to play. I want to play with this because I really was excited by the idea of being able to have e-consults available to the primary care providers in all 8 of our federally qualified health centers that make up Community Health Center Network. So that began a long and continuing to this day relationship with Rubicon. We initially started with essentially a subscription model where we, CHCN, paid for the providers to be able to use it. But as we worked on that, it really became clear that we needed a more formal sort of capitated arrangement. CHCN holds specialty risk from 2 health plans, Alameda Alliance and Anthem Blue Cross, and hence we have specialty dollars to use. So we developed a capitated arrangement in a contract with Rubicon and worked very hard to promote this to our primary care providers. We have about 450 PCPs spread throughout the 8 health centers. We wanted it to be health plan agnostic and truly for all patients in the health center. We realized early on that you can't ask PCPs to say, oh, for Anthem, I push this button, and for Alliance, I push that button. We really wanted it to be across the board. So that meant as well that we were using our capitated dollars for all patients. And that was an ethical, philosophical decision that we were very comfortable going forward with. And really, Rubicon, I think, and the e-consult experience has been incredible for us. I'll do a brief sidebar to my own first Rubicon consult, which I think is really emblematic of how e-consults can work in our systems. I had a patient who had a pigmented skin lesion. I was worried about it. It wasn't fire alarm worry, this is melanoma, but it was like, oh, dang, you need to get to derm. And I referred her to derm and it went usual channels. A couple of months later, she came back And I said, so how'd it go at Derm? Of course, I hadn't gotten records. And she said, oh no, I didn't go. The papers got lost and blah, blah. And we had just started with Rubicon. I said, okay, let me get my phone. May I please take a picture? May I please send this to a dermatologist, an expert in the field, and let's get an answer for you right now so we know what to do. So I did the consult. I think I was like between phone and desktop, lots of technological challenges, but I got my answer back that evening, which was, ooh, ouch, this is really worrisome. You do need to send them to Derm and you need to send them now. This needs a biopsy. So I was able to call the patient and say, my specialist, the specialist I have in my hip pocket says you really need to go. And I also used that consult from the e-consultant in my consult to the dermatologist. And I actually phoned him as well. I picked up the phone and called the office and said, I really need to get this lady in. And ultimately, the story has a lovely ending. And then it wasn't melanoma. It needed to be dealt with. It wasn't life-threatening. But that really showed me the power of e-consult, the fact that I can get an answer really quickly that helps me hone in on the pace of what I need to do. Because usual channels didn't work. And I needed to really step it up, and the e-consult really helped me do that. Another story to tell is our CHCN's partnership with Alameda Health System, which is a really wonderful and ongoing story. So we are the primary care safety net, and our safety net specialty partner is Alameda Health System, AKA Highland. If people trained in the Bay Area, they know Highland. Amazing trauma center, really amazing staff. And in about, I guess it was 2016, we partnered with Alameda Health System and Rubicon to build a combined platform, if you will. So we set it up such that a primary care provider could send a consult, let's say to cardiology. It would go first to Alameda Health System. And if one of their consultants were able to pick it up and respond in the first 6 hours of the life of the consult, they would do that and send it back to us. If they couldn't, if they were busy, if they were, slammed in the ICU, after 6 hours, it would go out to the national network, and the CHCN PCP would still get their consult back. It was a really, really good arrangement. I loved how it worked. We even had a marvelous event called Consults and Cocktails, where we actually got our PCPs together with specialists. We did almost like a TED Talk stage. I still remember how lovely that was. And it was a really great way of bonding the two groups of providers. In many ways, we're now very siloed in our primary care silo and our specialty silo. We don't bump into each other. And this consult pathway, this electronic asynchronous consult pathway, was a really lovely way to develop those relationships. Things changed. We ended up both on different epics, and I'll talk a little bit more about how wonderful Epic is, and how the fact that just because you're on Epic doesn't mean that you're going to be able to talk super seamlessly with another friend on Epic. But that, to me, that period of time when we were together on with Rubicon as our platform was a really good illustration of how eConsult can pave the way to robust primary care and specialist relationships. So fast forward to challenges, and I'm so glad that there's a lot of expertise throughout the day to talk about bright spots and how many people in diverse settings have confronted challenges. So 2021, 2020, absolute challenges, of course. COVID slammed into our life in early 2020. It hasn't been the same since, and I don't think it will be the same. People talk about getting back to normal. I often like to say, well, normal wasn't that great to begin with, and let us try to create a new normal. So in terms of COVID, I think we do see, and other speakers will speak to this, very clearly pent-up demands. I know for myself as a primary care provider, I am seeing people come in with more advanced issues, breast masses that have gone, under the radar. People have been scared to go to mammography, scared to come in, CHF that is much more out of whack, cancers that are more advanced at diagnosis, and of course, anxiety. I think providers are anxious, patients are anxious, and it's just been a very, very challenging time. We're coming up and out of it. I think more of us are having on-site visits as well as telehealth visits, but eConsult will absolutely play a role in getting patients more expedited workups for these conditions that have been sort of smoldering along without the attention that they could have had if it weren't for the pandemic. Another challenge that we face is workforce issues. I used to think workforce issues were bad. They've gotten worse. There's a collective exhaustion among healthcare providers in general. I don't need to tell this audience that. And I think that collective exhaustion is super clear in primary care. My own clinic, the clinic where I've been since '99, has had just a number of staunch primary care providers move to different places. Some have retired, some have followed other passions, but we're really thin. And it's really hard. And so how do we ask primary care providers to really do even more? eConsult is an incredible gift, and we can't get away from the fact that it takes time. It's easy for me to say, send to cardiology. CHF needs evaluation. I can do that in 30 seconds. It's not awesome. I can certainly do better than that, and I absolutely try to. But the eConsult, it takes more. It's fantastic, and it takes more time. So I think we really do have to think about these workforce shortages. In addition, in our FQHCs, we're also working with nurse and MA, all staff shortages, just tremendous turnover. We've had multiple health centers that have had to close to new patients because they just don't have the staff to take care of them responsibly. So how do we engage primary care providers in using eConsult? I think within our partnership with Rubicon, we've tried many, many different ways. I think that we've done competitions, the clinic that has, the most eConsult wins a pizza party. Those sorts of things have been really important. We've worked to get Rubicon and our eConsult platform into the orientation, so that when a new provider comes on in a health center, they learn that, there's this thing I can use. And in fact, our CMOs report that it's a recruitment tool. But again, engaging PCPs and supporting them in the work of doing the eConsult is very, very important. We've worked with some ideas of how we might use medical record staff, nursing staff to support the eConsult, but it's challenging. And all those workforces at all levels are hurting. So we need to really think outside the box and figure out how we're going to do this. So I mentioned before a little bit about our relationship with Alameda Health System. Long, deep, mission-driven, partner. So we are now on different instances of Epic. CHCN works through Ocean Epic. Alameda Health System works through Foundation Epic or Mother Epic. And they don't always talk, right? So Care Everywhere is awesome, and I can see stuff that happens, but it's very challenging for me to actually engage in a conversation with somebody at Alameda Health System. We developed a whole very complicated workflow with Epic Care Link. in order to get those going, it really relies on our referral coordinators to do the heavy lifting, the copying and pasting, which is kind of not fair. We took our, non-degreed, non-licensed staff and threw a burden on them to make this e-consult thing work. And we're looking at that. We're trying to make it more smooth. And is there a way to really make that flow better? It's been a long and heavy lift with a lot of really beautiful partnership on both sides, but we're not quite there yet, I would say. The other piece that we're doing is we're also working with other partners within Sutter to use Care Everywhere Referral Manager in Epic and some of the messaging functioning. Again, the devil is in the details here. It's a lot of heavy lifting, making sure addresses are right, all of that. But I think there really is very good work to be done, looking at how can we make the technological pieces of the provider, of the PCP to specialist conversation easier. And there's a lot of really good work to be done there. So again, I've talked a lot about challenges, sort of Laura Miller as voice from the trenches. And I want to conclude, I think, with some bright spots that I see. And of course, open it up to questions. And I'm thrilled with the expertise in the Zoom room. I do think that there's a lot of creative ideas out there for additional workforce that can help with e-consult management. For instance, is there a role in medical records? I remember the days when, the shelves around the provider room were full of paper charts and the shelves fell off the wall because of the weight of the paper charts. I remember medical records staff literally trolling clinic, looking for charts that had gone lost. That's a workforce that really is morphing into an information management workforce. And is there a role for somebody in that capacity for supporting e-consults? Is there a role for medical assistants? Again, it's a short workforce. There are definitely challenges, but I think that there may be role there. And then I spoke a little bit about it, but I think there's tremendous promise in how can we hardwire e-consult into Epic? I mentioned a little bit our work with Sutter. We're trying to use CIRM. In a sense, we actually jokingly call it CIRM Lite. So it's not full-on Care Everywhere Referrals Manager, but essentially a light touch, but it's trying to open those conduits of communication between primary care and specialty. And I think another solution that we're working on, we've had challenges with specialists saying to primary care, oh, your consult questions aren't that good, make them better, do better. So we're actually reigniting a pilot that we had considered doing with Alameda Health System around some very specific referral questions that are built into our Epic. Lifelong, my health center does it with DME. Like I can't do a DME order without really specifying all the things that I need. Well, maybe I should do that for cardiology, and I shouldn't send a CHF consult until I have an echo report and I can flow in that information. So I think there's tons of room for improvement, for opportunity. And I go back to 2008 when I saw that retinopathy camera on Hoopa and realized there's tremendous power in this. And it's just really delightful to see all the passionate brains working on the problems. So with that, I will close. And I think Hilda and I enter a conversation with all of you.
Thank you, Dr. Miller. We have time for questions, so I encourage you, if you have questions, please submit them in the Q&A, and I'll be happy to relay those to Dr. Miller. We do have one question. You mentioned that e-consults are dependent on work and support from non-credentialed staff. What is most helpful to these team members? Is it extra time set aside to do this task? Do you have other suggestions?
Yeah, time. Absolutely, right? Time is the commodity that is the most challenging, right? I think time set aside to do it, and then also training. It's going to take training in terms of what are the key pieces of information that may need to be loaded in, and then making sure that the pathways for keeping that communication going are clear and consistent. I think those are the things that would make it work very much. So we can think about, could it be centralized in a health center? So for instance, some of our health centers are very big. Lifelong has multiple sites. Could there be one e-consult manager that sits in a central location or sits in their home, but the system is set up so that e-consults flow through them and that they are responsible for, uploading any additional data and then getting the consult, helping the consult get back. So I think some creative solutions could happen there, but it is dependent on training and time, which is money.
Thank you. Dr. Miller, you shared with us a number of different experiences. What are some key lessons learned you think that would be helpful to this audience?
Oh my goodness. So many key lessons. One, I think that, always having an enthusiastic champion is really important. The classic leadership buy-in is important. We sort of, I say it's a classic, and I say that, because we hear it so much, but it's really, really true. Our CEO, Ralph Silber, really believes in eConsult, and basically anything that is going to support primary care providers and improve patient care, we're going to try to figure out how to do. It took a lot of creativity and a lot of patience and a lot of hard work, actually. So I think those are some key lessons. And then, there's a question in the chat about primary care providers and time in their schedules. And I think that is something that we have not yet conquered. It's been challenging to get time for dealing with the inbox. But I do think that dedicated time for eConsult in the schedule would be very, very important. It's sort of melded in with all of the other administrative tasks. So that's a challenge, but I think that if that were recognized, it would be absolutely important. And it would encourage. So often as we've gone out to the different health centers to sort of talk about the benefits of eConsult, people with primary care providers have rightly said, and how am I supposed to do that? I'm charting at 10 o'clock at night. I got kid pickup. I've got bath time, bedtime. I'm going to be doing my charts at 11. And how am I really going to do this? So I think it's part of the challenge of how do we make primary care livable?
Thank you, Dr. Miller. We have a few more questions. Do you have metrics or a quality review to show you where improvements in utilization may be needed?
We have dashboards for sure that look at numbers of consults over time. I think there's a lot of more work that we could do talking to our primary care providers about what their pain points are, sort of really taking a human-centered design approach. And we really, frankly, within CHCN, we have not had the bandwidth to be able to dig back into that body of work. It's our own, COVID being slammed by COVID that we really haven't had the time. I want to look at that question though. Was it because yeah, metrics show a quality review to show where improvements. Lots of different ideas. Yeah, and we definitely have done some qualitative work. I think we need to do more. And I have to say, the local Rubicon team has been a very good partner in this, in terms of really trying to dig back in with our primary care providers, figure out what their challenges are and help solve some of those.
Thank you. Another question. Do you have any messages you would like to send to policymakers around supporting e-consult adoption? Good question.
Yes, do it. I think one of the take-home points from what I've been saying is that it is a beautiful modality, is an incredibly beautiful modality, and it takes work to make it happen on the part of the specialist and the primary care provider. I think I've focused more on the primary care providers' challenges because that's the world that I live in, but also the specialists, they are, taking care of patients in person, they are running codes, they are doing all the things. So if we're really going to leverage the beauty of e-consults, there has to be carved out compensated time to do that. I do think that alternative payment methodologies that are on the horizon bring some hope there, but I think we also have to really have a laser focus on it and call it out. Yeah, so I would say, keep the pressure on, keep the policy advocacy pressure on, and it is a very important modality to improve care across California for sure.
I have a comment and a question here. So important to move more care into our world and our patients' community of care. What's in it for managed care plans and our payers? Is there clear benefit to them to help to financially sustain e-consult?
I would say absolutely there's clear benefit. For one thing, I think we can feel fairly certain that people can get better care. So that CHF patient, that CKD patient, they may not end up on dialysis. We're actually launching a very cool population-based CKD program with Rubicon. It's been slow in getting off the ground because everybody's so harried. But ultimately for payers, I think that the health of your population will improve. Would you not rather pay for a chronic renal insufficiency consult, or would you rather pay for years of dialysis? It's a little stark to put it that way. And can I say that that's absolutely, going to happen across the board for everybody? No. End-stage renal disease will happen. Bad disease happens. But I do think that timely and most importantly, specialty care that is easy for the patient is really an important step and will have benefit. Absolutely. Absolutely.
Thank you. You mentioned specialty care being a benefit to patients. What are some of the benefits to providers? I know when I wrote the story about Camarena Health Center, Dr. Ramirez, the chief medical officer there, stated that one of the primary benefits was that doctors, primary care providers, didn't have patients contacting them constantly saying, when is my next appointment? When am I going to be able to see my doctor? And so that creates an added stress for PCP. So just wanted to ask you the same question.
Yeah, I think it's a really good point. And I think one of the things that we thought about, and I think did happen, is primary care providers get a little chunk of education with every consult. And the consults often come back with, thank you for asking this question. If this patient were to walk into my office, this is what I would do. So you sort of get that little hit of gratitude, which is great. And you get a chunk of learning. You get a chunk of education about, okay, these are the things to think about. And these are the 3 or 4 steps that I would do. So every eczema picture that you send, you're just reinforcing your own internal knowledge banks about various conditions. I mentioned workforce issues. We often hire new grad NPs, and I love this workforce, and they are really thrown into the deep end sometimes in their first couple of years out. So it's hard on them, and it's hard on the seasoned providers who are precepting them. because again, that's another piece where there's not built-in time too much. But Rubicon is a huge, our eConsult, and eConsult can be a real huge source of support and education there. So I don't know if I completely answered the question, Ilda, but certainly those are the thoughts that come to mind.
Thank you. Appreciate your thoughts on that. So one of the questions that I had was around buy-in. You mentioned that getting buy-in is very important. And one of the things that I learned in doing the story about the Central Valley and Camarena Health Center is that they have buy-in from the top. Camarena is very invested in new technology and innovation, and are really leading the Central Valley in the work. So I wanted to ask you what your thoughts are on getting that buy-in. What can providers, community health centers do to get that?
Yeah, it's a really good question. I do think leadership buy-in, as I said, is absolutely important. I think it is showing the value of eConsult, showing the impact on PCPs and on patients and an overall care for the population. I think those of us who went into healthcare, those are the things that we really care about, is, you know, helping patients feel better, helping a whole population health improve. And it may vary leader to leader. You know, some leaders may really respond to stories. So maybe my melanoma knot story is a good one. There's so many wonderful success stories for eConsult. Maybe it is return on investment that will speak to the leader. It really does depend on what will best speak to them, but there's data out there. There are many, many stories out there. And I think how to make it sustainable, you know, that's also super important.
Thank you. Another question that we have here is, I'd love to know how folks on Cerner, CERNER, facilitate the PCP specialist relationship back to PCP eConsult Volley. We're using the tool messaging pools, but it leaves much to be desired.
Yeah, you know, I don't know Cerner. I'm a survivor of NextGen. I'm a current Epic user. So I do see in our own Epic, there's some really great stuff that happens with bubble chat. And that's what we call it. I don't know if everybody else calls it bubble chat, but it's essentially, you can talk to anybody. It's like text messaging within your system. So if we could get something that's as easy as bubble chat, Epic to Epic, that would be amazing. We'd have to, you know, like any texting platform, you'd have to have rules. And I can see specialists getting challenged with multiple PCPs bombarding them. But I think if we could make it as simple as that, that would be great. Right now, the way our messaging works, it's pretty challenging. We just haven't figured out a good way yet to get easy provider, you know, PCP to specialist messaging, either from our Ocean Epic, either to AHS or to Sutter. And that, I think, is one piece that is really important. So you have to get the technology down such that it's easy. We all know this. If there are tech barriers, you know, just getting single sign-on has been really challenging with Alameda Health System, and we're hoping to get it soon. But that's another barrier, right? I can't wait 2 minutes for a token. So if we can get single sign-on, that might help. If we can get the messaging better, that might help. So getting the tech. And then I do think there's going to be a sort of etiquette and communication norms that we're going to need to work on as well. But I do think having it be easy is really important.
Thank you. Another question. How do you recommend the delivery system transition to this hybrid telehealth / e-consult in-person way of delivering care, since we're still working in an in-person only world?
Well, we're not in an in-person only world, really. So I think that I mean, it's a related question. I think that, having the telehealth modality is incredibly important. COVID taught us that. We've flipped on a dime. In the space of a week, we were doing it, which there's so much history to be written about that, and change in humans. It's just really fascinating to me. But I think we are existing in a hybrid world of in-person and telehealth. I'm hoping that we can continue that and improve it. So many issues there. I could go on and on. And I think that the insertion of e-consult into that is, in a way, it's the same challenge as it was before COVID, in that, how do you get the time to do it? How do you get the technology? So I think it's really a fascinating question. And I want to talk tons about telehealth, because I do think it's an amazing modality, and it's really moved us forward. And I don't think that the insertion of telehealth really changes the challenges and the benefits of e-consult. I think they remain. It's that we have an added way of communicating with patients. And it could be that, wouldn't it be cool? And I know that Rubicon is working on this. Could I have a video appointment with my patient and then video in the consultant? That's really cool. And that's not my idea. That other people have talked to me about that idea. I think that would be utterly amazing. So that marriage could be super cool.
Thank you. You talked about how we're living in a new normal, basically. Where do you see e-consults in the future of healthcare delivery? I know that's a very broad question, but really wanted to get your insights on that, given your experience with technology and innovation and all that you've done.
I think it absolutely has to be here to stay. And like so many things, if we can get the financing of it right, if it becomes recognized as a compensated part of the work, then it becomes another tool. And I really do think the tech is hard, but hopefully, there's a lot of smart people that do tech. I think that the smart people can work that out. I do think that the financing and the operational pieces of who does the work and how do they do it, and is it a recognized part of primary care and specialty care, I think that those pieces definitely need to be worked out. I know there's a lot of work on that. And so that will really help cement it as a real part of care delivery. A whole nother body of work that I do is around community health worker workforce. And literally over the years that I've been working on this, it's now a Medi-Cal benefit. CHW work is a Medi-Cal benefit. CalAIM and enhanced care management. Whenever I say that sentence, I'm utterly delighted. I don't think I foresaw that when I came to CHCN and started working on CHW workforce pieces. Visionaries saw it. I didn't necessarily see that it was coming, and here we are. So just as there's been tremendous movement towards equity with the CHW workforce and that modality of taking care of patients, I think the same can be true for e-consult. And should be true.
Thank you. There's a comment in the chat that I wanted to bring out, because I know it's come up quite a bit in the work that we do at CHCF. And that is, sometimes you have a PCP or a specialist who has a bad experience with functionality or quality, and they may be reluctant in using the technology in the future. What do you have to say about that? What recommendations or maybe lessons learned do you have that you can offer to this group?
Yeah. I think one, fix it, make sure that it's fixed, and then really say, please try again. we're evolving, just as your patients evolve, just as children evolve. Things aren't always perfect, glitches happen. And I think also too, we hear your feedback. We heard your bad experience. We get it and we fixed it and it's durably fixed. And don't go back and ask them to use it again until it's really fixed. I think that's probably the piece that I have. And some things are really challenging. Like one of our health centers doesn't have really good Wi-Fi. It's taken a really long time to get that fixed. But you can't ask people to beat their heads against the wall, trying and trying and trying with a functionality that doesn't work.
Thank you. It sounds like you really have to listen to your PCPs and talk to them and be patient with them.
Absolutely. I often say doing work in the primary care clinic is trying to deliver care inside a blender. It's crazy. Primary care is really challenging, especially I think with the populations in the federally qualified health centers, because they are a population, they are people who've suffered such trauma and their lives are very, very complicated. Yeah, but they deserve the best. That's one of the reasons why I've been, so interested in eConsult for as long as I have.
Thank you. Any parting, I do see one last question. What role should patient navigators or care coordinators play in eConsults?
Great question. And I think it goes back to what I was saying earlier about how can we be creative in terms of other workforce that can support eConsult. So I think they could absolutely play a role in eConsult. A lot of, I think, what patient care navigators do is help patients manage their way through a very fractured system. So perhaps it could be, a role in communication with patients to say, hey, your doctor got a consult back and there's this new medication. This is what it's about. I might be, say I'm that provider, I might be getting the consult, enacting the recommendation, and then saying, hey, please tell the patient that Dr. Miller did get the consult back. The specialist wants you to try this and that. So a role in supporting the communication could be utterly cool. I think we'd have to think about, as we ask patient care navigators or CHWs to take on roles and responsibilities, it's really important that they be well trained to do it so that they are not out on a limb. So training and time, back to those core principles.
Thank you, Dr. Miller. We're getting close to finishing up the hour. Just wanted to ask if you had any final thoughts or words for everyone here.
Really, I'm just deeply appreciative of the time that all of you have given today, and also all the work that you're doing to push this work forward. As I say, I feel like a mere co-writer in the storm, a voice from the trench. And, there's so many good brains working on this, and people with good heart and good soul and good brains. So I just really appreciate the work and really look forward to what the next years bring us. There's a lot of really great promise.
Thank you so much for joining us today. We're truly honored to have you here with us. You mentioned something about people deserving the best, and I think that's why all of us are here today. We see eConsults as a way of doing that. I keep referring to Camarena Health Center, but that story was particularly important to us at CHCF because it really highlighted a lot of the barriers, the obstacles that people face, and the importance of eConsults to providing access to quality care now and in the future. And there are just so many lessons learned from that one particular story. And I encourage you, if you haven't had a chance to read the story, to do so, and would love to hear your feedback on it. With that, I'd like to go ahead and turn it over to Libby, since we are at the top of the hour.
Thank you so much, Ilda and Dr. Miller. What a great and candid conversation. It's always nice to hear the real world experiences of the clinician and team We appreciate CHCN's involvement in our eConsult work group. Gosh, you mentioned Ella Schwartz. Ella, if you're on today, you've always been such an active member, and Dr. Miller, you have too. It's been great to have your voice of experience over time. And Ilda, it's been great to get to know you too. And your blog, your article and interview about Dr. Ramirez was so important for us to see. Our Central Valley eConsult Coalition that we'll be hearing from in just a bit here it's great to have Dr. Ramirez involved. He may be popping in on today's call too. So with that, I'm going to introduce our next panelist, or actually our next moderator. Dr. Greg Buchert is going to lead our next panel. We are honored to have Dr. Buchert as our eConsult work group advisor. And Greg, we've known you for many years now too, and it's been so great to see your consistent leadership of telehealth and eConsult. Dr. Buchert is Chief Medical Officer of the California Medical Reserve Board. In his past life, he's been CEO and CMO of a number of managed care plans and a leader of telehealth. So Greg, I'm going to pass it to you to introduce the panel, and thanks again.
Thank you, Libby, and it's great to be here. Good morning or good afternoon, depending on where you are. And just I'm going to pause a second about the California Health Medical Reserve Corps, because it's something that many people may not be aware of. And it's a federally designated nonprofit organization that connects public health, health delivery systems, and community organizations to coordinate responses to disasters, but also building community resilience to deal with disasters in the future. One of the exciting things that I think you're going to see some overlap in the future is that our intense focus on community-based efforts are now serving as a model for the larger Vaccine Equity Consortium, a collaboration among United Way, Easter Seals, Microsoft, Amazon, and other organizations to use lessons learned from the pandemic and including use of technology to leverage that to increase immunization rates, improve health screenings, and even moving into addressing social determinants of health in the future, not only in California, but across the country and across the world. But today, we've got a great panel to discuss the use of eConsults during disasters. And as many of you know, whether it be a wildfire, a hurricane, a flood, these types of disasters really impact individuals, families, communities, and the providers that serve them. So today, to discuss that, we've got a panelist represent primary care providers, health systems, and specialists. And they'll be discussing how to use eConsults to address disasters and community crises. So to kick us off, I'd like to introduce Dr. Alanea Stevens, who's the medical director of Chapaday, an Indian health center in Northern California. So Dr. Stevens, please, after you.
Thank you. So today we're going to talk about eConsults. We are a tribal FQHC up in Auburn and Grass Valley in Northern California in the Sierra foothills. And you know, the past 2 years have brought pandemic and wildfires. And so eConsults have been very helpful and instrumental in providing support to our patients and our providers in that. So next slide. I wanted to spend a couple of seconds just talking about how the pandemic has affected tribal communities. And we've definitely seen that in our patient population. American Indians and Alaska Natives have a higher risk of COVID-19. And when you look at 18 to 64, you see disproportionately American Indians, have the brunt of that. And these are people who are taking care of the elders in our community and children. And so it's definitely impacted our patients. We've seen families be hospitalized and really be affected by this in multiple ways. And so we've done lots of messaging and education around COVID-19 vaccines and around protecting our elders and our culture and our way of life there. And the eConsults have really allowed us to help fill in some of the gaps for our American Indians. around COVID-19, but also some of the deferred care that we've been seeing throughout this pandemic, and allowing people to still stay home, as well as provide them specialty care from a source, their primary care provider, who they really trust. The other thing that we have seen throughout the last 2 years is just resurfacing of historical trauma. I think it's been in the news about Canadian boarding schools, and some of our elders and their families have kind of been a direct victim of those. And so just keeping in mind that when we are treating our patients, that there are so many different things that really affect someone's health. And it's for this reason that maybe American Indians have higher risks of diabetes and substance use, and require more specialty care there. And then the wildfires came to kind of add to the layers of trauma there for our community. And so we continue to provide care with full PPE. We're kind of forced to kind of differentiate between symptoms of COVID and smoke. And we relied heavily on using telehealth and e-consults for our displaced patients who were living in shelters at that time or with family. And so this kind of looks at what our utilization has been for e-consults throughout the last 4 years. And we have definitely seen that when we do put an e-consult in, almost 80% of them are being able to be handled by the provider in the e-consult, with only 20% needing further telehealth or referral to specialty care. And it's really just provided primary care support during disasters, and it's allowed our PCPs to help patients who've had barriers to transportation. Broadband access has been an issue in our rural communities. And so e-consults being asynchronous has been really helpful in allowing our providers to discuss this over the telephone with patients or in clinic. And then just local specialty access in rural communities like ours have been hard and take sometimes 2 to 3 months for folks to get in. So it really helps expedite that care and prevent harm by that wait. We also see a lot of unstable housing and displacement through the disaster, which has definitely compounded all of this as well. And so I'm going to stop there and hand it back to Greg.
Thank you so much, Dr. Stevens, and thank you for bringing that, particular cultural perspective to consideration that often we don't think about. We think about technology and patients as a whole, but each patient has their own unique cultures that need to be considered. So thank you. So next, I'd like to introduce Doctors Petra Steinbuchel and Michelle Riederer, who lead the Child and Adolescent Psychiatry Portal at the University of California, San Francisco, Benioff Children's Hospital, to talk about what they're doing in the area of e-consult, especially dealing with the impact of the pandemic on individuals.
Great, thank you so much. So our program is not a novel program, but it's considered a pediatric mental health access program that now exists in over 30 states. And if we can go to the next slide. We know that the past couple of years have brought all kinds of challenges for youth. And even before this, that 1 in 5 kids have a diagnosable mental health condition, and that 50% of all mental illness onsets by age 14, 75% by age 24. And that suicide is the second leading cause of death amongst young persons ages 10 to even 34. And meanwhile, there's a significant lag time between the onset of symptoms and the time to diagnosis and treatment, sometimes 2 to 4 or even 10 years. And now you add on a global pandemic and the challenges of e-learning and the social isolation that comes with that, and difficulties around immigration policy, as well as significant number of the worst of California's wildfires in the past 5 years. as well as all kinds of anti-immigration and really kind of structural and systemic racism that's been very publicized in the news, that's added significant amount of stress to all of us collectively. Next slide, please. So this was a quote from the Little Hoover Commission's report that was just released in August of 2021, talking about how COVID has created a perfect storm of stress, anxiety, and trauma, and has exacerbated a pre-existing crisis in children's mental health. And experts are warning of a further looming tsunami of unmet mental health needs amongst young people that we are just beginning to see and expect to see increase over the next 1 to 2 years. Next slide. This is a quote from the California Emergency Survival Guide. And just to highlight this piece, that if you have a tsunami coming, move to high ground. As soon as it's safe to move, go to higher ground. Do not wait for an official tsunami warning. So we have this warning already in place from the Little Hoover Commission, and we do need to think about how we can do things differently. We have to chart a new path and can't just continue to refer out for all of children's mental health services. Next slide. Part of the reason for that is that we don't have enough providers to be able to adequately address the current need. This map at the bottom of this slide shows the workforce shortage of child psychiatrists, but there are similar figures for child psychologists as well as developmental pediatricians and other therapists. And essentially the workforce is about 1/5 of what it needs to be. And we expect that at least 25% of psychiatrists in the state of California are going to retire within the next 10 years. And so the American Academy of Pediatrics, as early as 2002, released this statement around delivering care within the medical home. That is a model of delivering primary care that's accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective to every child and adolescent, and that this care is easy for the child and family to obtain, including geographic access and insurance accommodation. So we are proposing this as a workforce development workflow that can help kids access the necessary care and ideally support rational utilization of child psychiatrists and other mental health specialists for the most severe and complex presentations that are in number 5 on this pyramid diagram. And meanwhile, in the number 1 at the bottom of the pyramid, PCPs are addressing the needs of most of their patients. And then with increasing need in the categories 2, 3, and 4, that PCPs can manage mild to moderate mental health conditions with consultation and support. And with that, I'm going to turn it to Dr. Reeder.
Thank you, Dr. Steinbushel. Next slide, please. Okay, so Dr. Steinbushel was able to highlight, the current needs that we have both nationwide and specifically in California surrounding, the lack of access to specialty mental health care. And so again, our program is not a new or original program. We are modeled after other child psychiatry access programs that have existed around the United States since 2000, since the mid-2000s. And these types of child psychiatry access programs, our program includes several arms, one of which is the e-consult piece. So the few arms that we have, one is that real-time direct connect consultation. And traditionally that has been through sort of a telephone consultation model where the primary care provider is able to call in and pretty much immediately speak with a child psychiatrist who is able to offer guidance on a particular clinical case and discuss, next steps and potentially the appropriate, place to refer or whether medications or other, treatment recommendations are appropriate. And then we are very excited to be rolling out the e-consult piece of that consultation model So again, this would be less of a real-time consultation, but more of an asynchronous ability for primary care providers to reach out to us and provide some brief clinical information and receive guidance on next steps and appropriate treatment recommendations, again, from our child psychiatry consultants. The other pieces of our child psychiatry access portal arm are one is education, which we believe is a really important component of these types of programs. Of course, every consultation we consider to be an educational experience, because the PCP is not only learning about how to manage the particular mental health question that they have for their patient in that situation, but also able to store that information for the future and really develop increased comfort and skills and knowledge in addressing mental health concerns in the future. But we also have a wide number of CME events, as well as website resources and website educational materials to access at any time. And then we have something called a second step psychologist consultation, which is a direct consultation for families and primary care providers to speak with one of our child psychologists. And then finally, the last arm of our program, which we are now fleshing out, is the care coordination piece, which is really helping families and patients connect to care when specialty mental health care is appropriate. Next slide, please. And here we just wanted to highlight, that the e-consults, specifically what we're offering, can really exist on a continuum of, different types of behavioral health integration. On the far left side, we have patient-facing technologies such as apps and web services that can assist with mental health care. And then, as we go more comprehensive in nature, we see e-consults around the middle here, which can be, a nice consultation platform for primary care specialists to ask specific questions. And then, farther to the more comprehensive and integrated side, we have the collaborative care type of model, including, co-located care. And then, the very far end would be direct evaluation with a psychiatrist. And, there's value in, different pieces of these models. But I think one thing that we really wanted to highlight is that often, earlier on in the less integrated side, such as the e-consult side, there's been evidence to show that for the field of psychiatry, even e-consults, done as the initial step can reduce consultation to psychiatry by 25% or more. Next slide, please. Here we just wanted to highlight the types of questions and consultation categories that we've received. So CAP launched in September of 2019. So we recently passed our 2-year birthday. And since then, we've been collecting information about the types of consultation questions we get, as well as the demographics of the patients that we're serving. This is a little out of date. This was collected back in June. So our numbers of consultation is about 900 as of today. But, when this data was collected, we were able to see that a lot of the primary consultation questions do surround medication, but that there are a wide variety of, other questions that PCPs do call in about, including, overall questions about treatment planning, questions about resources and referrals, diagnosis and behavioral management. And as you can see, the secondary question that often arises during these consultations is around treatment planning, 40% as kind of the secondary question. And one thing we really wanted to underscore is that, although often the questions that come in do surround medication, that, our goal is really thinking about the whole child and thinking about, what truly is appropriate for the child from a holistic point of view. And so, of course, if medications are, appropriate and would be helpful and indicated, we're very happy to provide guidance to primary care providers about medications. But again, our our aim is to really think comprehensively and to think about what other, treatment modalities and supports in the community and around the child could be helpful, not only the medication piece. Next slide, please. And so I won't get into the details of this, but just wanted to highlight that there are a lot of strengths of the eConsult model. Again, we have both the eConsult option and the telephone consultation option with our CAT program. But that with the eConsult question, this is an example of a sample consultation that we've received in the past. And the provider is able to provide a lot of background information about the child's prior history, including the services that they're receiving, such as behavioral therapy, what school supports are in place, and the situation and the question that is really arising for the PCP at the current time. And then our consultant is able to review, all the information that the PCP has provided and answer questions in a comprehensive way that provides, kind of an overview, not only surrounding the medication piece, which is highlighted here, but also surrounding diagnosis. So the consultant is, recommending additional questionnaires that could be helpful for the PCP to utilize, as well as, how to start and choose the medication, and then really how to titrate it, as well as including potential screening tools and handouts that can be attached along with the eConsult. Next slide, please. And then alternatively, on the telephone consultation piece, again, there can be really a wide number of questions that we get called in about. Some are, more straightforward, some are more complex. We tend to think of the telephone consultation as more, helpful and appropriate when there is a really complex case. And then in terms of the eConsult piece, that can be really beneficial for more straightforward questions that can be sort of, answered directly, versus with a telephone consultation that really fosters a discussion and potential, exploration alongside with the PCP about what might be going on. And again, with the eConsult piece, just really, I think one of the main benefits is really helping with the PCP workflow and being able to manage that in an asynchronous manner. Okay, thank you. And I will hand it back to Dr. Boucher.
Great, thank you, Dr. Reeder. And sometimes we think in California that we have all the disasters, wildfires, earthquakes, pandemics, landslides, but they do occur across the country, across the world. And to really broaden our geographic perspective and bring us home, I'd like to introduce Dr. Emily O'Neill and Shakira Green to share lessons learned about using eConsults in disasters from the perspective of New York City Health and Hospital, the largest safety net system in the country. And so please proceed.
Awesome. Thanks for having us, and excited to join in this really inspiring conversation. So I'll introduce, and then I'll let Shakira introduce herself. I am a primary care doctor. I'm an internist and I see adult patients for 50% of the time that I work in one of our FQHCs in Queens. And then the rest of the time I spend doing EHR optimization. We have Epic. And a lot of that optimization is getting at this nugget of specialty access and patient communication and decision-making support through referrals and email. Do you want to say hi, Shakira?
Yeah, good afternoon, everyone, or good morning, wherever you are. My name is Shakira Green, and I'm the Director of eConsult Implementation at New York City Health and Hospitals, and I oversee the implementation throughout our different hospital facilities and also our communities rolling out eConsult. So I'm so excited to speak to everyone today. You can go to the next slide, please. So as stated before, New York City Health and Hospitals is the largest safety net system in the United States. And New York City is very diverse, and you can see that represented in our patient population. We serve the 5 boroughs, which would be Queens, Brooklyn, Manhattan, Staten Island, and Bronx. And 25% of our patients have limited English proficiency, and we're able to assist them with access to care by providing interpreter services for about 190 different languages.
Awesome. So because of how logistically and geographically complicated a system like this can be to navigate for a patient, I would say that eConsult supporting primary care providers and managing most conditions without necessarily needing to get a patient to be seen at from my site in Queens, there are 2 neighborhood hospitals that we have that we'd be sending them to. Those things were priorities before COVID, and obviously I don't have to tell you how disruptive and horrible COVID was in New York City. So we certainly had a fire lit under us after the disaster began. Just to this slide here is just because there can be some overlap in terminology. We thought it was worth briefly just walking through the workflow that we've built and how we strategize eConsult as a system. So Shakira and her team, their role is to engage each at each of our 11 hospitals in whichever community clinics offer specialty care. They engage those teams, get their buy-in, train the providers who will be handling the e-consults on the workflow. And then once that's all done and the specialty at that site is turned on, all referrals from an outpatient provider, which is in most cases the PCP, route via e-consult. So that's a little different. Places where you know, a provider might have a choice between e-consult versus traditional referral. Then this diagram shows what happens once that changes occurred and a referral is sent. So it hits this specialty provider's in basket. They review the chart and make a decision, which looks like one of 2 things. One is that, so for instance, a dermatologist looking at a photograph of a lesion in the patient's chart review might say that needs a biopsy right away. So there's no need for me to go back and forth with the provider about this, schedule the patient to be seen. So that's on the left side of the screen. And then on, I'm sorry, on the left side, no, right side, is the yellow side. This is more, I think, what people mean when they use the term e-consult, where it's a conversation that happens between the referring provider and the specialist that doesn't always necessitate the patient being seen in person. So that usually looks like a couple different possible outcomes, as you can imagine, and some of those, you know, don't end up in the patient presenting for the visit. In number 2, I think are the most common way this looks, but is that there's some support given for the decision making and some additional intermediary workup that's recommended before a decision is made about a patient being seen. And then the third one is, so as you can imagine, in a system as complex as ours, where we have a lot of providers like me sit within the hospitals that we send most of our patients to get specialty care from, we may not know exactly where a patient should be seen, or if there's, for instance, like I'm sending a patient for a flutter to general cardiology, and I didn't know that there's also like a rhythm clinic. They may intervene to redirect that referral before a slot is taken. In the old way of doing it, a patient gets a visit they didn't need, and that's of both parties' times. So that's just a little overview on how we have this set up. You can go over to the next slide, please.
Yeah, so to Emily's point, the communication that eConsult helps to provide is very important because it streamlines that communication for the providers to communicate with one another, in addition to helping to avoid any unnecessary visits for patients. And then we can also see here, we done a research study looking at the impact or the role of eConsult in ambulatory care during the COVID-19 pandemic, and we had studied the baseline of November 2019 to January 2020 versus during COVID, which is March 2020 to May 2020. During that time, we did see that we were still able to roll out eConsult. That did not stop at all. And in fact, it rolled out even faster during that time. And we saw that the utilization of eConsult was quite effective during COVID because we were able to resolve more e-consults via electronic consultation, so they didn't have to result in the patient, which was definitely very important during this time where if patients did not have to leave the home or have to, be outside and, with everything that was going on during COVID, it was very beneficial to have that resolved in another manner. And next slide.
Awesome. So I'm not going to read through each of these in detail, but just in broad strokes, these are all examples of real e-consults that were placed and then responded to a patient needing to see that provider. In the first example, where a patient was referred to cardiology, the only question they had was, why is this patient still on DAPT? And the cardiologist says, unless there's another reason that you know of that's not in the chart, they shouldn't be. So that I think is a good example of what did that need to be a 20-minute visit that a patient had to take public transportation to be seen for? No. Similarly, the GI example, unaware that the study with a suboptimal prep actually was sufficient to have this patient follow according to the 3 to 5 years that a tubular adenoma buys you, because they got enough visibility to make that diagnosis and have a biopsy to prove it, which I certainly would have known as a PCP, but again, it means that's a colonoscopy that a patient doesn't have to repeat now. In the example referring to breast surgery, so again, something that to the PCP in the biopsy report appears to be something of a diagnosis that needs surgical intervention. They carefully reviewed the chart to say, okay, the imaging and the biopsy findings looks like we got the right place, and that's actually a benign diagnosis. So patients saved from needing to feel like they need a procedure or get seen by the surgeon. And then last, so the example of a referral to additional specialists by someone already being followed for their heart failure. When they saw that there was a report of elevated right-sided pressures of the heart. So the pulmonologist says, cardiology's really got this. It's all the heart failure, which I feel like is a common thing once a person has a heart failure, that it does affect obviously other organ systems. So I think the other, and people have been saying this, but I feel this pain in our system where we take care of such a huge number of complicated patients and, have limited resources when it comes to primary care time, but specialist time, perhaps even more, is we're not trying to prevent patients from being seen who need to be seen. We're just trying to balance that correctly and get the patients who need to be connected, and empowering the PCPs to make decisions for those where they don't need to be seen. So go ahead and flip ahead. Awesome. So this, in conclusion, I think, my feeling as a primary care doctor is that it's of extreme value to me to be able to tell a patient, I'm talking with a specialist about the problem we've discussed in your visit today. I'm pointing exactly in the chart. I've either documented things or whether that be in photograph form, in written word, or pointing them to in other places in EPIC. It tends to make the clinical question pretty clear. And when the dialogue takes place, as we were just looking through, I feel like people have already pointed out what a continuing education opportunity that is for PCPs, but I've also seen that work in the opposite direction. So for instance, I had referred a male patient of mine for infertility to a urology doctor at one of our hospitals who wrote back, no one in H&H like that provides that care, which was his impression, just sitting within the hospital he worked at. And because I do work with Shakira and her team on the enterprise side of things, I know that can't possibly be the case. I found out where it was available and wrote that back to him and said, our patients, they're mostly not privately insured. It's not like think we want to prevent leakage from our system from a business perspective, but also we know that we're often the patient's only choice. So it makes sense to have everyone be as aware of the multitude of services we actually do offer as possible. And then lastly, I think again, to reiterate the point about wanting to balance our access with patients who actually need it. One other thing I'll say is mostly Spanish-speaking patients, and I speak Spanish with my patients, to feel like I'm helping them navigate a system that is mostly in pockets. There are Spanish-speaking providers, but I don't know how to guarantee that when I'm sending a referral. If that means the conversation is happening between us in my office over the phone, a video, or they're actually coming in, I think it does a lot to sort of empower my voice to my patients. So it's something I take a lot of joy in, and the reason I work on it when I'm not in clinic is because of that value that it brings. Awesome. I think that's what we got.
Great. Thank you, Dr. O'Neill. And I want to bring this back to the disasters aspect of it. Dr. Stevens, I'm going to look to you. In contrast, where New York, it's a whole health system where everybody is somewhat connected and geographically located. For the e-consults that you're doing, your specialist may be somewhere across the state or somewhere across the country that may not be aware of the disasters that are happening in your community, such as the wildfires. Are there things that you need to put into your e-consult to the specialist to heighten your awareness? The fact that the person you're asking a consult about may no longer have a house, may have lost a family member, may not have transportation. And should that play a role in your e-consult as you structure that? Dr. Stevens?
I think that the strengths of e-consults is that it really puts the care in the PCP's hands, and they understand that patient so well. And so when we do write for those e-consults, they're very specific questions that we're asking. And so, because we know what those barriers are when we ask those questions, we don't often put a referral in where we feel like we won't get a useful response back. So that's definitely kind of put in mind when we do that.
Okay, thank you. And for the UCSF folks, Dr. Steinbuchel, how do you see your program scaling? You showed your map with broad representation around the Bay Area, but California, like many states, are making major investments in behavioral health, especially behavioral health for children. And how can that investment made by a state help you expand your program or other programs like yours?
Yeah, great question. And it is kind of $1 million question, or in California's case, $4.4 billion. But we just recently received national HRSA funding to expand actually throughout Northern California to all of the 48 Northern California counties. And I think that there is, significant recognition now about mental health impacts and the need to address mental health. It's been one of the few silver linings of COVID. And we are trying to leverage some of the state proposals around, they want to improve consultation to schools. And so we're looking at a school-based consultation pilot and being able to improve mental health literacy amongst teachers, and also trying to use teleconsultation and e-consults and providing that increased support in order to empower pediatricians. And then we are looking to develop a platform that actually would allow care teams to communicate with one another more easily in a HIPAA secure way. We've often dreamed about being able to have the PCP and the teacher and the therapist and, the CAP consultant be able to connect and talk and maybe push out, rating scales to kids and communicate with them as needed. And so we're hoping to get some alignment with some of the initiatives in the budget.
Great, thank you. And then for the New York team, you mentioned about the diversity of the population you serve. And, everybody has their own culture, their cultural beliefs, their cultural norms. Is that something that needs to be a component of your e-consult? Because when you consult a specialist about a disease, he or she is often going to be looking at it as, let me treat that disease, without that eye to the individual behind the disease. And so how do you bring color to your consults to highlight the cultural norms that need to be considered?
Wow, tough one. I think first, that is a risk, I think, too, of communication that's 100% electronic and based on in a record, which can be, it's usually pretty dry. But it also, historically has been a place where a lot of stigma was baked into the words that we use to talk about patients and to talk to patients. So I think I am a strong advocate for primary care being, the home, so to speak, for patients. And I think that is where we invest our resources in terms of having openness and sort of inclusion in those environments. And so having, like, if that means that conversations that would have been a patient telling their own story in a room that you wouldn't otherwise have access to, moving that back into to the primary care office, I think that's one control the tone and the context and allow opportunity for questions, and like the focus on continuity is there, the focus on relationships is there. I don't know that we have thought about how to enfold that into like the electronic architecture that like supports communication in this way. And, it's an interesting question. I think Epic has certainly come a long way in terms of what it's possible to document in terms of, not just racial and ethnicity data, not just language, but also sexual orientation and gender inventory. So, I think our system as a whole is working on how robustly, but also sensitively that stuff is documented, and hopefully that means that communication of this type, is sensitive to those things. But that's a good thought to think about, specifically for eConsult. And I don't know, Shakira, if you have any thing to add. I've given a long-winded answer as usual.
Shakira, any thoughts?
Hi. Oh, no, I was just going to say, I completely agree with what Dr. O'Neill was saying. If anything, it does give food for thought. So that's something that I would definitely like to think further about, because those are, it is a sensitive topic, making sure you have those connections with your patient and making sure their needs are addressed appropriately.
Okay, I'm going to give you all the jump ball of for any of you to provide any final thoughts before we wrap up.
I did want to add that because it's so focused on the medical home and primary care providers, which are so important in this, I think when we think about reimbursement, it's very specialty driven, but we should also talk about supporting the PCPs in that way, as well as it does add additional work to their workload. And, they are on the front lines kind of facing a lot of these disasters.
Well, good, thank you. I couldn't agree more, Dr. Stevens. In fact, I just wrote a recent blog on that was just published in the Capitol report about that very specific issue. So thank you. And what a great way to wrap. Well, I'd like to thank each of the panelists for bringing a really stimulating discussion. And with that, we'll turn things back to Libby.
Thank you, everyone. I'm actually going to hand it to my colleague, Robbie Franceschini. We appreciate the moderation, Greg, Dr. Biekert. We also appreciate your advisory role to the eConsult work group. Thank you for your work. And thanks to our panelists.
Thanks, Libby, and great to be here today. And shifting gears a little bit to the policy landscape and lessons learned from California from some policy efforts here around eConsult in 2021. I'm really excited to be joined by a couple colleagues on this panel. Michelle Canales from the Office of Senator Ana M. Caballero here in California, Mohit Ghosh, who's a VP of Government Relations at Anthem, Kelly Beam, who's a government affairs advocate with HealthNet of California, Paul Glassman, who's Associate Dean and Professor at California North State University, as well as Trong Lee, who's Director of Government Affairs with Local Health Plans of California. Good to see you all here. So before we jump into a discussion around California policy, just moving to the next slide, we wanted to share out, as we do each year, just our 50-state scan of Medicaid physician fee schedules, just looking at, where are Medicaid programs reimbursing for eConsult? Are they reimbursing for PCPs and or specialists? And what's the change from last year? So as you can see here, all the green and blue states are reimbursing at least for specialists and or PCPs. 22 states now reimburse for specialists and PCPs per their physician fee schedules. In those 3 new states this year over last year are Louisiana and Wisconsin and Massachusetts. So we'll make sure to keep tracking that and report out, in coming years. Would also encourage folks to, if you're interested in finding out what your state reimburses, the eConsult work group's happy to help you with that, or would recommend to just, keeping an eye out for those different fee schedules that states maintain, waiver programs, dental homes, behavioral health, right? We know there are lots of variations in terms of what different Medicaid programs cover. So shifting gears just to California, we're here today to kind of discuss, lessons learned from this year. There was a bill introduced that really had, I think, really awesome multi-stakeholder widespread support around eConsult reimbursement for PCPs and specialists, as well as those billing through federally qualified health centers and rural health centers as well. Unfortunately, that bill was vetoed by Governor Newsom here in California this year. But, I think we're really here today to discuss, what we learned from that effort, as well as, how can we think about looking to the future and how eConsult can be incorporated into various health reform efforts in this state. So, whether that's legislation or through other efforts like our Medi-Cal stakeholder advisory group that's underway right now, efforts like CalAIM, which is, a huge state investment in transforming how we pay for and deliver care within the Medi-Cal program, as well as other efforts like our alternative payment methodology discussions underway for our health centers and public hospitals as well. So first, I'd love to turn to Michelle. And Michelle, we really appreciate, Senator Caballero and leading the charge around SB 365 and Medi-Cal reimbursement, Would love to just turn it to you, maybe to tell us a little bit more about why the senator decided to introduce the bill and really why e-consult's important to her constituents.
Thanks, Robbie. Hello, everyone. Michelle Canales, Senator Caballero's office. I staffed the senator on the bill she authored, SB 365. So this bill would have required Medi-Cal to reimburse all participating primary care providers for e-consult services. And she wanted to extend that reimbursement to those who worked out of an FQHC or an RHC. So I'll talk a little bit about, how she got involved in this issue and the district that she represents. I think that was a real inspiration for her. She represents Senate District 12 in Central California. It's a very rural region. And when she was actually campaigning for her Senate seat, she heard from a lot of future constituents that health care access was a really big issue for them. Primary care providers were often like an hour away in some of these small rural towns. And transportation is a really big issue as well. If you don't have your own car, public transit is not entirely reliable, and it's definitely not frequent in a lot of places. So a lot of these people were having to, get their family members to drive them. It was really an all-day event to go to the doctor for a lot of these people. And that's for primary care. When someone had a condition that required specialty care, they often had to go like up to Silicon Valley, Palo Alto, or down like Bakersfield, LA, even depending on which specialist they needed to see. So this was a really big theme that she heard, and she, was looking for a way to address healthcare access. Of course, the pandemic was also going on, so she was extremely interested in telehealth services. She saw that as a really big opportunity for people to, get quicker access to care. And e-consult kind of fell into our lap as we researched this issue for her. We met with Blue Path Health, and they kind of gave us background on the issue. And she was really intrigued. She felt like this was a reliable way to get patients care quicker for, more non-urgent concerns. So for the rural patient, if a referral is needed, the way she kind of saw it is they'd go to their primary care doctor, and the e-consult could be done. And if, a referral is needed, the primary care doctor, still having that conversation with the specialist, could, order labs, blood work, x-rays, whatever might need to be done, send that over to the specialist. So when that appointment does happen, perhaps months later, it's an appointment that, is really well used for the patient. Like the specialist has all the background information already, and can talk about next steps instead of like more information gathering at that appointment. And then of course, one of the biggest benefits of e-consult is a lot of the time a referral is not needed, and the condition can be, managed through the e-consult, whether it's like a change in prescription medication or a follow-up that's scheduled. I think, you've heard a lot of examples in the previous panel where, the referral just wasn't needed and it would have been an unnecessary appointment. So the senator, saw these things as a really great benefit in general, but especially for the rural resident. Unfortunately, as Robbie mentioned, the bill was vetoed, despite a lot of bipartisan support and a lot of support from several different sections of industry. However, the senator remains committed to healthcare access issues. And I think that as we went through this process, we really learned a lot about how it is right now in California, what the mood is for e-consult, and kind of where the barriers are to achieving, what our bill would have done and getting that reimbursement for the primary care provider. So lots of lessons learned, and she's still willing to look into this issue and kind of determine, what the best next step should be.
Excellent. Well, thanks, Michelle, and thanks so much for the senator's work on the issue too. Although SB 365 was ultimately vetoed, as you mentioned, it gained a lot of bipartisan support from legislators and widespread support from different, healthcare organizations. I'd love to turn it to Mohit. What are some of those learnings that we can take away from this effort as we kind of chart different policy pathways to ensure, reimbursement or other kind of acknowledgement for e-consult and asynchronous telehealth as well?
Thanks, Robbie, and thank you everyone for joining the annual meeting today. We are excited, of course, at Anthem to have been able to help with this effort. And I say help with this effort because it doesn't happen just because Anthem wants it to happen or one company wants it to happen. It happens because there's a grassroots movement that comes together because people see the value in what's being delivered. And that's really what led to our involvement in supporting not just the piece of legislation that we are discussing that unfortunately was vetoed, but that's really what led to our push into the Central Valley with this e-consult network that we've tried to build in the coalition that we've built. So none of this could have happened without all of the FQHCs and the RHCs that got involved. None of this could have happened without the vendors that were willing to come in and figure out how to make it work in some very hard circumstances. And everything that's been said, California right now is investing heavily in infrastructure build out, thanks to the budget surplus that we face. So it is disheartening that a critical piece that we see as an integral tool, if you will, for primary care physicians to not only build that stickiness with their patient, give their patient a medical home, bring them in, more often to make sure that all of their conditions, including SDOH issues, are being handled within that clinical setting. It was disheartening to see the governor's veto, especially because there's been such a move to rewrite all of California Medicaid, right? We call it Medi-Cal in California, but for those who are from other states, it's the Medicaid system here. So we continue to be hopeful that we spent a lot of time educating people this past session, and we're hopeful that that education starts to bear fruit. In rewriting the waiver for California, we have to also think through, whether we could have those discussions, as Robbie mentioned earlier, directly with DHCS. There's a lot of waiver changes that are going to occur. And maybe, yes, we need this as a benefit in legislation, but maybe there's other ways to get at expanding access to e-consult. For us, it was a very straightforward calculation in terms of this is a fruitful first step, as others have said. It does not replace in-person visits when those are needed, but it really does allow for PCPs to not only build their knowledge base and for their front offices to build their knowledge base, but very importantly, allows them to help that patient, that member, in Anthem's case, manage their healthcare better. And that's why we were so supportive of the effort to get this over the finish line. The irony is that the specialist does get paid, right? But the PCP, who is gaining the knowledge, who is keeping the patient in a medical home, unfortunately is not. So that's where we continue to keep our focus, is that ultimately this grassroots movement will lead to the pilot being recognized, that the pilot that we have built with the coalition in the Central Valley will be recognized. The data will be analyzed a little bit more, and that maybe we can go from pilot to program within the Medi-Cal payment structure. So that's our hope. But as Michelle pointed out, lots of lessons learned, and we're not going to give up on it because we feel it's integral to our overall telehealth strategy. We want to be a digital first company, and that means all modalities used appropriately for the right audiences, the right patients at the right time. So thank you, Robbie, for letting us be a part of the coalition. And thank you to Blue Path for actually helping us build that coalition.
Yeah, of course. And thanks, Mohit. And thanks too, I think for bringing up, that I think a lot of e-consult programs are some are newer, some are older, but it's, I think, making that bringing those proof points to the department to show really how this does expand access to care and sharing all that good data we're gathering here today. I'm so glad, Trong, you were able to join us this morning. And just a little plug, really thankful for the work you really contributed to this bill and some of our technical assistance and research on the back end, and in your former role at the California Primary Care Association. Would just love to pose the same question to you briefly. What were some of the key learnings you came across as we were deep in this process and in trying to discuss different reimbursement options with the department over the course of the last year?
Yeah, can everyone hear me okay?
Mm-hmm.
Okay, so I would say that in my previous role at CPCA, I think the clinics want to do this, and they want to find a way to bridge that access barriers between the patient and the specialist. And we CPCA was a strong supporter of AB 365. I think the lesson learned that I took in my previous role was that there was still a lot of confusions regarding how clinics are paid or how providers are paid, and more even like how e-consult work and what the benefit of e-consult. I think in my current role with the local plan, right, LHPC is also a supporter of SB 365. And I heard story from plans on how they partner with providers in their community, trying to provide e-consult services and trying to enhance that access to specialty care. So we hope to continue the conversation with the department and with partners like everyone on the call today, to explore different way to make e-consult and reimbursement for e-consult services a reality in California.
Excellent. Yes, I think we learned a lot about health center reimbursement the past year and the different options. And I think there's still yet work to be done to sort of educate folks around the different policy options that do exist. Kelly, I'd love to turn to you, to hear more. Health Net and California Health and Wellness have had some e-consult programs live for a couple years now, and have spread through the Central Valley through the new coalition effort. What's some of the data that we really need to highlight, as these policy discussions continue into the next year and beyond?
Thank you, everybody. I appreciate being invited to speak about Health Net's experience. And like Mohit mentioned, we really definitely see the value in the Central Valley pilot that we helped fund. And I think, that 80% resolution of, electronic consultations is a really important statistic. And I know it was talked a lot about during the advocacy for SB 365. And I think we all have to keep in mind that, the best policy takes multiple years, sometimes in multiple rounds of effort. But also, trying to keep in mind that, we also need to weigh in on a lot of the other goings on at the department. And the more the department hears from us on this and, all of our proof points, I think it will have a wonderful effect, and hopefully we'll have a great outcome. And, I think, legislatively, sometimes it's hard. We all want a bill signed, but I think if we're able to have the same effects at agency without, we should also have a bill, don't get me wrong, but I think, some people, it's not as flashy of a win, but if we're able to get that policy in place, it's definitely effective. I would just say, my prior role at CMA, the California Medical Association, it was interesting. We heard from a lot of our providers in the Central Valley pilot program, and that was, different health plans coming together with a number of IPAs and other stakeholders to create kind of a one-size-fits-all, but a unified approach. So when you're approaching a practice, to make sure that they're going to participate or be inclined to participate and continue on with the pilot once, that initial startup funding is expended. You want to make sure that across different payers, they have, similar processes. So I think that's really important, just minimizing that workflow effect, because, they could choose to see another patient rather than, having to coordinate the e-consult. So we want to make sure that, like Dr. Miller mentioned in her keynote, it's important to incorporate the e-consults right into the workflows, because they do bear that administrative expense. They're trying to help out with this passing SB 365. But in the meantime, I think doing everything we can as payers to make sure that it's a streamlined process and that we are able to incentivize what we know works in the environment is really important.
Excellent. Thanks, Kelly. Dr. Glassman, I'd love to hear from you as someone who's been, I think a real champion for asynchronous telehealth over the years, and as someone who, sits on the department's telehealth advisory work group right now. What are some of the key issues you flagged in those discussions? Really, I think, too, what do state policymakers need to be aware of when it comes to kind of acknowledging e-consult or asynchronous telehealth more broadly within, the different policy frameworks being developed?
Yeah, no, thank you very much, Robbie. And, as with the DHS Telehealth Advisory Committee, on that committee, I am the only oral health person there. So I was honored to be that, and also honored to be a part of this panel. Obviously, there are some differences in oral health delivery compared to general health. We use different tracking systems, different coding, different billing and payment systems. But in fact, many of the issues are actually the same and important. I highlighted yesterday, I'm going to just repeat just very quickly here, that we have a huge problem with access to care, particularly in the Medicaid program in California with access to oral health services. Less than 50% of Medicaid beneficiaries get any oral health care at all in any given year. And in general, access to primary dental care is not available, and access to specialty and referral and consultation is just not a possibility at all in oral health care, given the current structure and payment system and the way things work. So I've been involved, as you mentioned, for the last several decades in using systems that primarily use asynchronous store and forward to reach people and provide dental care that are not getting care. And what we found is that by bringing oral health providers, typically a dental hygienist, into a community location like a school or a Head Start center or a nursing home or a residential facility for people with disabilities, they're collecting records. They're having a dentist who's not on site through a telehealth connected team provide that consultation and direction. And we've found that we can actually keep most people healthy in community sites and avoid that trip, which is so difficult for so many populations, to a dental office or a clinic. In fact, we found that 2/3 of children can have all the health care that they need, all the oral health care they need, performed in a school or a Head Start center, and be kept healthy and verified by the offsite dentist as being healthy. Now it's really astounding. You're talking about populations of children who typically get no care at all until they have advanced disease, end up in the emergency room, not with a toothache, not learning in school. And to be able to keep those children healthy at the school site using a telehealth connected team is really a complete game changer for our health system. In the work I've been talking about, the main providers in the system have been health centers. And unfortunately, they're not allowed to establish patients as their patients using asynchronous store and forward interactions. So that results in all kinds of wasteful workarounds that they have to do to have some kind of in-person interaction, which is completely unnecessary in terms of the care that's provided, but only in order to get paid, they have to go through wasteful interactions. And it also just limits the number of providers that are willing to be involved, and it limits the access to care, and it limits the ability to make a huge difference that we know we can make. So, yesterday I talked about the importance of DHCS adopting what they're referring to as billing and utilization protocols for telehealth that covered services, regardless of the modality or the method in which those services are provided. And from my view, and particularly from the perspective of oral health, the idea of e-consultation is just one example of that principle. In oral health care, we know that consultations between specialists and primary care providers can be performed using asynchronous store and forward record review, as well as record review plus synchronous interactions with either the referring provider or the patient or both. All those things are possible. And in any of those systems, I think the important thing to be thinking about is the responsibility of the consulting provider to determine if they can have and document that they have the information that they need, to make a decision and make recommendations for further care or diagnostic procedures. But here's what's critical. This is no different than a consultation performed in person. So there's a tendency to think about services performed using telehealth as somehow less than or less effective than in person. I think it's just time to get over that mindset. And it's time to adopt a policy environment where we acknowledge that it's the responsibility of providers to determine if they can provide an e-consult. That means, again, determining if they have and can document they have the information needed to make a decision and recommendations for further care or further diagnostic procedures. And if they do, they need to be reimbursed for the time and services they provide. And that's regardless of the modality used. And that means in person or using any of the telehealth modalities. And it's across all health conditions and delivery systems, including oral health. So thank you for the opportunity to have a few reflections on oral health and how it fits into this world.
No, thank you, Dr. Glassman, for all your work. And I think that last point too around, I would say kind of viewing telehealth and e-consult just as healthcare, right? And not trying to put, technology-based care really in a separate box all the time is a key point to highlight. I think that's a really good segue into, this final question I have for each of our panelists. The department has outlined a couple different guiding principles as they're looking to, come out with some policy recommendations through this work group, things like equity, patient choice, program stewardship, access. And I think we can see these principles as kind of applying or really having resonance kind of not just within the Medi-Cal program, but more broadly when it comes to e-consult and in thinking about, guiding principles more largely in healthcare. I would love to hear from each of you briefly, what's one recommendation that you have for our state leaders in general when it comes to ensuring we reflect these principles in our policy, especially when it comes to e-consults. And Michelle, maybe I'll start with you.
Sure. One thing I had thought of, I think there's a general willingness in the legislature to move something on e-consults. I think the benefits are pretty clearly recognized. I thought one thing that would, be beneficial is to see if there's some version of a pilot project that could be worked out with the Department of Healthcare Services, similar to what Mohit said. If, we had a small scaled down version where the benefits, the cost savings could be realized, I thought that would be, the most compelling evidence to pursue something, on a larger scale.
Excellent. Mohit, I'll turn to you next.
So ditto on that, and I'm hopeful that the pilot that we are all in together, both in the Central Valley and now expanding it into the North Country as well, will continue to yield the type of data that we should be able to take to the legislature and to the agency. I will, however, hearken back to some of the earlier discussions that we had as part of this meeting today. I don't want to lose sight of all of the modalities, including e-consult. I think the work done by the UCSF CAP team is also integral to our ability to deliver timely services for kids. In fact, some of you may not know this, but as part of our coalition, we are actually working with UCSF CAP to deliver those asynchronous child consultation services for psychiatric purposes. And we're proud that hopefully will also start yielding some results. Again, modeling legislation based off of pilots that actually work, in my view, will continue to be, I think, a key piece of how we approach our advocacy on this. But really, I learned a long time ago that data speaks louder than anything else. And if we can show the data and we can convince the department as well as the Department of Finance, which is very, very powerful in California, that there is a realistic return on investment here, that's going to move the needle. And, I just thank all of the team that's in this coalition, including all the IPAs, the FQHCs. Let's keep, I know it's sometimes drudgery to report and create the data sets and create the dashboards, but I have to say that that's something we have to keep our nose to the grind there, because that's what's going to make the difference.
Excellent. And Kelly, I'll turn to you.
I think I want to go back to what Michelle said in her opening comments about, members not being able, or, not having a car to make it to their appointment, and having it be, a day that they have to take aside to go to the primary care office. And if they're able to get, some of their other challenges addressed while they're there, or, with a provider who's familiar, I think that's really what equity is all about, making it so that it's more equal, where you can access these type of specialty appointments is really important. So I think, Mohit, we need to figure out how, we turn over those 186 clinical sites in the 20 counties that this is happening in, and, say, like, let's make this a pilot and continue to fund at least those folks who are willing to be kind of early adopters, I would say, and make sure that, they're able to continue all that wonderful good work, over those, I think 10,000 visits have been performed this way since 2016. So I'm excited to work on it next year.
Excellent. And Trong, I'll turn to you next.
Yeah, I would just say ditto to everything that folks have said. I think access is important for us, for the local plans. I think building that evidence-based understanding of telehealth in eConsult is important, right? Because we want to make sure whatever we're proposing will work and work efficiently for Medi-Cal beneficiary and also for the state, right? I would want to emphasize too that I think one of the concern or one of the consideration that we have as we engage in the DXCS telehealth work group is, let's try to create so many rules on telehealth. Let's simplify it and get creative, right? We already have enough rules from the federal government, so let's not try to impose additional one in California and get creative, whether it's a pilot, whether it's a grant funding project, so that we can understand how it works, so that we can understand how beneficial that will be for the patients. So that's what I think that we should try to focus on.
And Dr. Glassman, I'll leave it to you to wrap us up.
Yeah, sure. No, thank you. Well, I think first of all, I don't think it's been said in this panel yet, but I think it is important to recognize that DHCS does have a responsibility to ensure that our taxpayers' funds are used wisely. And that does mean having a policy environment where we address their legitimate concerns about waste and fraud. I think sometimes those concerns drive policies further than they need to, but I think it's also not fair to dismiss them completely. So I think it's important to think about the fact that they have a responsibility to think about those things. But the good news is that there are clearly reasonable, and they use the term reasonable guardrails that can be put into place. In fact, another bill that was vetoed by the governor in the end of 2020 was AB 2007. Great to see Trong Lei, hey Trong, on this call, because he was very involved when he was at CPCA and working on the coalition that put that bill forward. But it included a whole bunch of policy procedures that would ensure that if health centers are establishing patients using telehealth, and particularly asynchronous telehealth, that it was done in a way that these would be legitimate referrals. They would have the kind of information they need. So it's already all written into proposed statute, but that was passed unanimously by the legislature. So it's possible to develop really good guardrails and still be able to allow health centers to do the things that we're talking about in a way that ensures that it does meet the department's stated goals of access, choice, equity, and at the same time uphold standards. And I think it's really all of our responsibility as we work with the department to make sure we are helping them with that responsibility of establishing reasonable guardrails, but allowing the procedures we're talking about to be done.
Excellent. Well, I think it sounds like data, equity, access, sketching up the guardrails are all key things we need to do going forward. So I think we've got some good next steps. And, I think I want to thank all of you for your time this morning. And really looking forward to continuing, the work on this subject in California, whether that's legislation or, agency education and everything in between. And really want to thank you all for your leadership and contributions to this work in your various ways. So thank you all so much for your time this morning. And with that, I'll hand it back over to Timmy.
Hi, Robbie. Thank you so much. And gosh, thank you all. I think this section, or I guess the whole day, we could also say we're pace setters and really setting the pace around e-consult adoption. And thank you for giving us, I think, what we can look at with SB 365 as model legislation for other states that are considering to go through similar rounds with their legislature. And just one thing that wasn't mentioned is that we actually sponsored this bill during a year of COVID. Our team has not spent a day in Sacramento inside the halls of the Capitol. And so I am hopeful that if we continue to go down this path, that we'll be able to help that understanding and be able to simplify and answer some of the confusion that we think we actually hit at the very end with that veto. So this next session, we're moving into, again, more pace setting and looking at what is happening across the country as we are re-envisioning reimbursement. And I think we all look forward to a day when primary care is moved out of a fee-for-service world. Frankly, specialty care has moved out of fee-for-service as well. So what we have for you are, I think, a fantastic 3 panelists that'll be able to share with you how they're thinking about e-consult as it's mirrored against where and how they're also testing new ways for paying and supporting primary care. We have today Amanda Barber from Arkansas Blue Cross Blue Shield. She works directly with primary care across Arkansas, and they also have an exciting pilot project with Peterson Center on Healthcare that we learned a little bit about on our last call last year. So we'll be able to dive deeper on how Arkansas Blue Cross Blue Shield is thinking about sustaining that model going forward. We're also joined by Dr. Jonathan O'Donnell, who's the Director of Specialty Care and Referrals at Aledade. And I think as our e-consult work, or the e-consult work group, this is really showing a level of maturity of where we are with the discussion, that we're able to bring in organizations like Aledade that are doing so much to support primary care and being able to adopt new ways of being able to collect payment. And how we'll hear from Aledade how they're thinking about e-consult in several pilots across the country, and where there might be some opportunities to be able to make it stick. And then finally, we'll also hear from Dr. Scott Shipman, who of course has been a friend of the e-consult work group from day one. But the work that Dr. Shipman is doing with AAMC and CMMI and CMS, I think is just going to be, or is incredible to be able to help this effort. And so we'll hear from him of some of the current work that's going on. So Amanda, I'm going to hand it over to you first. We've designed this to be a little bit more of, I guess we're going to try to call it a lightning model, where each of you will give us, a short synopsis of what you're doing, and then we'll move right into questions, and also really offer for each of you to be able to ask questions yourself to each other as well. So Amanda.
Thank you so much. Thanks, Timmy. So happy to be here today and talk about the exciting work that we're doing here in Arkansas. It was really great to kind of hear some of the previous sessions from today, and really hear that there are a lot of other states a little further along than we are in the e-consult world. But I'm really happy to share with you guys what we're doing here. So if you'll just go ahead and move to the next slide. This slide here represents our primary care team at Arkansas Blue Cross and Blue Shield. When we talk about providers and we talk about re-envisioning reimbursement and how payers are addressing the need for PCP support when we incorporate our advanced payment models, I think it's important to kind of start here and talk about the relationships that we build with our primary care practices, the providers, their care managers, and really all of the office staff. As a coach for Arkansas Blue Cross and Blue Shield Primary Care Department, we spend a lot of time with our practices As we provide support for these advanced payment models, Arkansas Blue Cross is the healthcare leader in the state, and we are the only private payer in Arkansas that applied to Centers for Medicare and Medicaid to participate in their Primary Care First program in 2021. With CPC Plus practices now eligible to join Primary Care First, we currently have a 400% increase in primary care practices joining our advanced payment model in the Primary Care First program for 2022. So beginning in 2020, Arkansas Blue Cross and Blue Shield, along with the Peterson Center on Healthcare and other partners, started a pilot program around e-consults and looking at the uptake of e-consults in the primary care setting and how we as a private payer can reimburse for an e-consultation. So this next slide here talks about what we hope to achieve with this pilot program. The objectives tie into the business plan for Arkansas Blue Cross and the ultimate goal of achieving the quadruple aim: better health, better care, better provider experience, and ultimately lower cost. So our objectives are, really looking at the experience, the PCP coordinating the specialty care for our members, navigating the health system for them, which in turn will we hope to increase our patient satisfaction, providing that right care at the right time, the primary care doctor and the specialist working together for the good of our members, treating the conditions at the appropriate level when it needs to be treated, looking to reduce the no-show rates, because that PCP has consulted with the specialist, the member's more likely to attend that specialist visit. And because, we know the PCP and the specialist both agree that that visit is or is not needed, and the PCP can keep the member in the office with them. We want to increase access to our specialist. Arkansas, just like the other states that we're hearing from, we do have a access problem. So hoping to include the right visit at the right time to show a reduction in some of the unnecessary visits. And we're hoping to open more time slots for the specialist, maybe even in their office as well. In increasing that primary care and specialist relationship, hoping to see some collaboration between providers for the good of the patient, records being shared between offices and the referral loops being closed. And then of course, we're conducting an ROI, looking for lower costs for specialty care, reducing unnecessary specialist visits, and increase the necessary specialty visits. Some of the principles that we have noticed are needed for this pilot program is an obvious PCP commitment. For success, we need the PCP and their staff to be committed in the e-consult process. We're also looking for some learning opportunities. Providers will learn how to complete an e-consult so that the benefit is continued, hopefully after our pilot program is over. Another thing we'd like to do is help the PCP and the specialist both work to the top of their license. That PCP being able to keep some of those members, those patients in their office, and hope to learn some things from that and meeting the needs of working the top of their license. And then lastly there, we're really looking at sustainability, the pilot being built so that learnings can be done and we can implement the use of e-consults post-pilot. So the next slide here, my last slide, just talks about what's next for Arkansas Blue Cross and the future of e-consults. We started in this pilot with 2 groups. We have an independent practice group where we have 10 practices utilizing e-consults within their clinic. And then we also have a specialist group where a hospital system is using e-consults inside the system. So as that is ending, we were looking for how can we support these practices post-pilot, and we're conducting an internal evaluation, and we're also having an evaluation done by Mathematica, a formal evaluation, to look at our policies and specifically how can we incorporate e-consults into our advanced payment models as we move forward in 2023. So, as a primary care representative and having my own experience working inside a clinic, I'm really excited for the future of e-consults and the ability for Arkansas Blue Cross and Blue Shield to provide that service.
Thank you, Amanda. And I know, you know, what we're really eager to see coming out of this pilot or your pilot is that you're working with the commercial population, which many of our projects, as you've heard from this morning, or many of the projects that are out there are really in the Medicaid space. So the fact that you're focused on that commercial population and then across all business lines is really, really insightful. It is incredible, and we look forward to it. So I'm going to move to and introduce Dr. Jonathan O'Donnell with Aledade. And Jonathan, I think you are just such a perfect role to be able to come in with both the PCP as well as the specialty viewpoint and how you are be able to support practices going forward.
Great, Jonathan. Thanks for inviting me.
Here you are.
You hear me all right?
Yep, I can see you too.
Great. So great to be with you all. Thanks for some time and attention. Look forward to some discussion after this. I'll be brief, but excited to participate here. I'm Director of Specialist Care and Referral, a new role created in the last 3 months that I filled. I live in Durham, North Carolina. I've worked across different healthcare entities at Duke and Blue Cross North Carolina before now working at Aledade. Go to the next slide. Do I control that, or? There we go. Great. So for those who may or may not be familiar with Aledade, just a brief update on what Aledade is and where we are. So Aledade aggregates independent primary cares into accountable care organizations and secures contracts across payer types, including Medicare, of course, but also Medicare Advantage, Medicaid, and a variety of commercial payers. We've grown to 36 states since being founded about 6 years ago. Lots of different value-based contracts that incorporate many different independent primary care practices and clinicians, and I think now like 1.5 million attributed lives. I share that because it's a great platform into which to insert e-consults, and that's what I inherited as I joined the role. There were a couple of e-consult initiatives underway, which I'm happy to touch on, as well as standing up even more. We think this is a very core offering for a variety of reasons. We go to the next slide. Many of which I imagine have been touched on throughout this meeting, throughout the day, including by my co-panelist Amanda earlier. But as I know from the delivery of care, as well as the interviews with the heterogeneous practices and PCPs around the Aledade platform, they all want to solve essentially the same thing, which is uncertainty about a given diagnosis or next therapeutic step. And hoping for timely, responsive expert input, as well as affable communication about that. Minimizing expense to see the specialist, the time expense as well as the money expense. Time expense in terms of the patient having to spend time and waiting in the clinic, lead time to the appointment, travel time to the appointment. And just the mental expense of uncertainty around treatment or care plan for so long. Similar for money, trying to avoid unnecessary or to minimize such expenses. Related is access, particularly for under and uninsured patients, as well as ensuring that patients who we want to see specialists end up seeing those specialists. So I'll touch more on that in a minute. And wanting to work with accountable specialists. So thinking about how do we foster those relationships in ways in which Aledade can help inform the accountability of different specialists by bringing to them different data and insights that we have in managing the total population that we think could also be a win-win or beneficial for the specialists. And the next slide, specialists also face these challenges. So I think a lot of the e-consult platform, at least as I've experienced it so far, is focused on the primary care side, but there's another user, and not just the virtual cloud panels of hand-selected specialists that might populate some of the e-consult platforms today, but the boots on the ground specialists in the same communities as the PCPs. And that has to deal with the preparation of the patient who ends up seeing the specialist, ensuring they come with a clear question, with the relevant information, with the right workup. And a lot of that can be accomplished in primary care. Doesn't need to be duplicated, doesn't need to be, oh no, we don't have that information, so let's spend this visit getting that information, the next visit actually answering the problem. There's appropriateness, just ensuring that what can be handled in primary care is handled in primary care, both to further equip and enable primary care to manage their population, in fact, even increase revenues in some areas. But also because every specialist I've talked to is overwhelmed. They're not looking for more patients necessarily, they're looking for more appropriate patients. For access, ensuring that our emergent and urgent patients have the ability to be squeezed in without being fully squeezed in a 5-minute visit, but actually having that access. And then understanding that in these communities in which Aledade operates, there are just such established relationships between the primary care providers and the specialists that's so important to acknowledge. It's not something that can be easily replaced, avoided, duplicated, but really ought to be acknowledged. So what's Aledade doing? Go to the next slide, and what are we thinking about? So we have 3 different e-consult initiatives in flight, 2 of which I'll term asynchronous, where a primary care clinician inputs a question or request to a specialist panel and receives insights in hours or days. And synchronous, where within 30 seconds we can be in touch with a specialist to accomplish the same thing. The specialist in the synchronous setting may be a local specialist. So how can we actually take what often transpires on the phone from an MD to an MD or provider to provider, or in text messages in a non-HIP compliant or non-secure, non-actionable way, and make that usable? Thinking about billing and reimbursement, Aledade is set up to benefit from e-consults just at its core, given the accountable care organization structure. So we are also interested, though, in understanding how to better use the existing coding, because that is what we might term good fee for service. If we're increasing our total cost of care by providing more immediate revenue to our primary care doctors in the moment, that can help pay for the staff in this time of incredible staff shortage, while the savings that accrue to the payer don't actually get paid out for 18 to 6 months later. In thinking about how to increase usage, the way I've seen is there absolutely are super users, like 1 to 2 users across hundreds of users who really use the bulk of the e-consult service. I anticipate it's actually the user. I think I've heard that there may be users who ask 1 user to become the super user on their behalf, but in general, there's definitely a steep adoption curve in terms of those who are super users, I should say, and those who can't be bothered, honestly. So how do we, Aledade's trying to think about what's the right messaging to make sure the value is known and the platform is known by the specific providers, but also thinking about how does an e-consult fit into the workflow of the provider and of the relevant staff member. And I say in the referral workflow because in many of the e-consult related asynchronous pilots, some feedback we've heard is that the specialist, while trusted, is unknown. So there's certainly a lot of familiarity and trust inherent in the local marketplace. So what if we are able to take those established referral relations and just improve the communication prior to a referral in a way that is seamless with the referral thinking? So a PCP having an established orthopedic surgeon who's high value and responsive, maybe having the ability to e-consult them ahead of a referral, and maybe avoid the referral 50% of the time. But when the referral is appropriate, and that's a much better prepared and informed referral. And lastly, thinking about how Aledade wants to support this itself through the revenue it generates in shared savings arrangements versus pursuing payer partnerships. So for 2 of the 3 e-consult pilots, we've been fortunate to have some joint collaborations with payers, and I think that's a great way to support our practices and support Aledade. But knowing that Aledade, as I showed, is a national company, we don't ultimately want to have fragmented e-consult platforms or support in certain areas and not in others, given we want to be able to supply such support across the country. So if there were one thing that may or may not be non-traditional in this particular arena, what I'm most interested in, happy to talk more about, is this idea of synchronous e-consults. I think that speaks to the earnest needs of primary care physicians on the ground today.
Thank you. Thank you, Jonathan. And I agree. And I think we'll hear more about how synchronous is being triaged today in our noon session. And then also the behavioral health piece with the warm line that was presented earlier for pediatric support is also kind of merging the two together. It's really exciting. I'm going to move to Dr. Shipman. Scott, are you there?
I am now.
Now you are. Great. We really look forward to hearing how you are thinking about, I think, the new era of reimbursement. You can take it away.
Great. Thanks, Timmy. Thanks so much for the invitation to be here. It's nice to connect with BluePath and all the attendees at the meeting today, and looking forward to the dialogue that we have with co-panelists as the session goes on. We can go to the next slide. Oh my goodness, got a little bit of formatting issues here, it looks like. Hopefully that won't throw me or anyone else off too much, but we have been at the eConsult game at the AAMC since 2014. We have a program called Project CORE, Coordinating Optimal Referral Experiences. And this started through work with UCSF, actually, initially as a content expert, and with funding from CMMI through a Healthcare Innovation Award in 2014, where we extended essentially and adapted the UCSF model, distinct from the now Zuckerberg model, but had a lot of success with that and had the ability with that CMMI funding to do a pretty robust evaluation of the program, able to show how eConsults plus enhanced referrals. John, to your earlier comments, we think it's really important to think about how do you optimize efficiency and effectiveness of communication and coordination between PCPs and specialists through eConsults, certainly, but also through improved communication and coordination and standardization on referrals. The model did improve timely access to specialty care. It did demonstrate a reduction in unnecessary referrals, and amongst PCPs, a reduction in referral rates, presumably for the low value referrals that they might have been making prior to the availability of eConsults. And from a payer perspective, particularly for CMS, we were able to demonstrate the reduction in specialty utilization and associated costs of care. Since that pilot with CMMI funding, we have continued to work with academic health systems across the country, expanding now by more than sevenfold. We're up to about 40 academic health systems across the country. I think we're in 26 or 27 states now, where we have helped them to implement comprehensive models in eConsults and enhanced referrals. And we're now working with health systems that in the aggregate care for north of 3 million primary care patients. Our model, it's important to point out, is really because we're working with health systems that employ both specialists and PCPs, you have to get the model right for both the primary care provider and the specialist. And as it relates to the behavioral economics of incentivizing the use of eConsults from PCPs and the willingness to participate for specialists, I think we have learned a lot about the information that needs to be obtained through eConsults and enhanced referrals, as well as incentive structures financially that align with comp models. So let's go ahead and go to the next slide. Most people know, oh good, this one turned out fine. Most people know this timeline of eConsult codes, but I'm going to cover it along with the context of our core program. So back in 2014, when we got started, the only thing that was out there was a series of unpaid codes, or bundled codes, the 99446 through 9 series, which are essentially a verbal and written eConsult, and they were really aimed at more urgent or acute needs between primary care and specialty care. As we got going with the program in 2014, modeled again after what UCSF had done and done well, we set up the program so that there were internal credits being provided to PCPs and specialists for every completed e-consult in an aligned fashion. So the PCP and the specialist each got effectively a 0.5 RVU, either against a benchmark or as actual above the line salary or funding for every completed e-consult. As we moved along with our pilot and were able to show the effectiveness of the model and the generalizability of that effectiveness across these centers, we began working closely with CMMI and then by extension CMS to discuss with them the logic of reimbursement for both the PCP and the specialist. And lo and behold, in 2019, the 99451 and 99452 codes were established at a 0.7 RVU valuation for each of the providers. The last session, one of the speakers said it can take several years for policy to get right, or something close to that. I think we are still in the phase of trying to get these codes right with CMS. In particular, the 99452 or the PCP code has a lot of burdens on it for providers or that impact providers and their willingness to use e-consults at the degree that we think would provide the highest value. And I'm happy to talk more about that, but in this lightning spirit of this session, we'll spend a lot of time on that right now. Our participating AMCs after these billing codes went live were a mixed bag. Some of them adopted billing practices right away once the codes were available. Others were seeing sufficient and compelling data internally that the program was working for them, that they didn't feel the need to implement these codes, particularly because they were concerned that it might have a negative impact on what was already working well for them and their providers. In 2020, CMS modified the consent requirement, one of those requirements that they built into these codes, to an annual consent. But from our standpoint, because there's also a cost share requirement of 20% with CMS reimbursements, it's really impossible not to inform the patient with every e-consult that the e-consult is happening and that they may see a bill for it. So the annual consent was well intended, but I don't know that it really transformed some of the burden on the PCP or their practice. This current year, we've seen a lot of movement by commercial payers and MCOs in experimenting with different approaches to the policies that the CPT codes from CMS laid out. And I'll talk about those on my last slide. The other recent occurrence certainly influenced California legislation in the end, and is also causing headaches in several other states, is a recent misinterpretation, we think, by CMS at lower levels within the organization that it's not possible to reimburse specialists for e-consults. And also happy to talk about that if people are interested in what we're doing on that front and the latest, but we're working to get Medicaid to rethink that logic. Currently, we are having increasing conversations with many payers and thinking freshly about how to incentivize providers within the context of APMs, and also happy to talk about that. Let's go ahead and go to the next slide. Here's some data that just shows the real world impact of the CMS codes coming into existence in 2019. So this is data from 3 academic health systems that started off working with us before the codes were available, and then turned the codes on and started billing and required of their providers all the things that are required to be able to bill for the services. And though the lines aren't perfect here, what you can see is the growth over time in the 6 months before these institutions started billing, and the immediate effect of initiating billing in the negative direction on the volume of e-consults that were being done. Now, it's worth noting that there was subsequent growth again of e-consult use after the billing codes went in place, but nevertheless, the codes did in fact have a negative impact on the use of e-consults. And that frankly has to do with the primary care burden. That the decision to do an e-consult is, of course, in these existing programs, with the PCP. And so this decrease was purely a reflection of PCP's perception of that burden. Next slide. Here's data from 2019, the first year the codes were available for the 99451 and 99452 codes from Medicare data. And you can see that neither of these codes were used all that much in 2019, but the vast discrepancy between the specialist code 99451 and the PCP code 99452. We've looked at academic health system data specifically. This is all CMS data, not limited to AMCs. But when we look at all payer data from AMCs for 2020, this discrepancy persists. There's been a significant, about a threefold increase in the volume of e-consults billed by academic health systems over those 2 years, but this discrepancy persists. And it's worth pointing out that a specialist can't do an e-consult and thus bill for it with the 99451 code unless the PCP has sent an e-consult question to them. And this discrepancy shows just how impractical the current 99452 code is. Next slide, please. So to sum up, I think it goes without saying that if you want to maximize the high value use of e-consults, whether you're doing that from a payer perspective or a health system perspective or a provider perspective, you need to provide an incentive to PCPs that is aligned with the compensation model. And even though increasingly health systems are moving more into the APM space, most individual providers are still working with compensation models that are fee-for-service predominant. That volume or productivity is the name of the game still for individual providers, even as health systems move more to APMs. So for the most part, this requires thinking about a fee-for-service equivalent, a per service offered incentive or payment to the PCPs. In the context of the 99452 code, I think things that could happen, and we're talking with many payers to consider, include these three bullets. One, shifting from the notion of consent, which requires the PCP to get that before they do an e-consult, to the notion of required patient awareness, which can happen as an e-consult goes out or after it goes out, for those situations where the e-consult question comes to the PCP after the patient is no longer at the office. For the 99452 code, one of the biggest barriers that I didn't detail at all has to do with the 16-minute threshold of time before the code can be used. In addition to having that 16-minute threshold, it also specifies that it's only the work on the front end of informing the patient and asking the question that can be billed. And frankly, PCPs would not do e-consults if it took 16 minutes on the front end to send the question off. So that's problematic. So we would suggest that either you should include both that front end work as well as the back end work. When the response comes back, it needs to be reviewed. An action plan needs to be put in place based on the patient's overall care plan, and the patient is looped into those next steps, or waive the 16-minute requirement altogether. Finally, eliminating cost share for patients is something we think is very important because PCPs are loath to burden their patients with the cost of their having to reach out to a specialist for some guidance. At some level, that is an impediment to the use of e-consults and these codes specifically. And as others have said, it's important that appropriate guardrails be in place. The worst case scenario from a payer standpoint would be a new reality where e-consults become a step in the process of every referral that they have to pay for. And that of course is not going to lead to an ROI that would lead to sufficient incentive to continue to use them. So I will stop with that and look forward to our discussion.
Thank you, Scott. Thank you, Amanda. Thank you, John. I am a little bit, you get to this place where you think that you've been really successful in being able to get the right policy in place. And then as we've had in the last two sessions, we have problems with the FQHCs being able to bill. Clearly the PCPs are not taking advantage of what we have, and we definitely need to make some adjustments there. And then Scott, you also alluded to some misinterpretation that's happening right now at CMS. I saw some chat on that on an earlier session from Colorado as well. Scott, why don't you just take a few minutes, just catch us all up, and how we might be able to, stay in the loop there. And then also if there's just a call to action for those that are on this call today to be able to work on the CMS PCP code, just what the specific action would be from all of us would be great if you could address those two things.
So Timmy, I want to make sure I'm tracking. So first of all, the latest with Medicaid, and then second, the what would optimal policy look like for the PCP code?
Well, really, what is it that we can do to help there? What is the pathway that you're forging, I'm sure?
Well, so we're definitely the more the merrier on this stuff. One of the things that we've heard from CMS on more than one occasion we've met with them is they're just not hearing any complaints from the field about these codes. And so there is a definite opportunity to raise awareness, and we can come and say we're speaking for the X number of academic health systems that we work with that serve X beneficiaries of Medicare and Medicaid. But it doesn't have the same effect as lots and lots of ongoing concerns being raised about these codes. So that would be an open invitation, and we're happy to provide language that we've used, if that would be helpful to get people with something more than a blank sheet of paper to start with. On the Medicaid front specifically, this problem just seems to me like it shouldn't exist. It's such a gross misinterpretation and inconsistent logic, both within Medicaid around payment policy, as well as across Medicaid and Medicare within CMS. So our next steps with this are, we are anticipating going to CMS to a high level administrator in Medicaid to, with the states of Colorado and Virginia Medicaid officials, to walk them through the lawyer's interpretation on our side, as well as the practical implications of blocking a service that has a disproportionate value for Medicaid beneficiaries in many states by virtue of their trouble with access to specialists in many cases. So that's our next step. We're doing this in partnership with Medicaid experts at Manat, who my policy colleagues at the AMC work closely with. And so we'll definitely let people know as that meeting proceeds what feedback we get and what the next steps are. There's also some work happening, I think, with the Association of Medicaid Directors, looking at taking their own tact at approaching CMS. And we have some emails going back and forth, but haven't connected to make sure that we're well synced up with that effort as well.
Fantastic. And I think someone else mentioned that HRSA is interested in joining the effort. So there's a lot, whatever we can do to help coordinate there. And I think just for all of you that are here today, I'll keep in touch with, or we will keep in touch with Scott and make sure that what letters you need, we're here to write them. So I'm just going to switch gears a little bit. Amanda, as we think about where you are in Arkansas and where you have coverage with large employers, commercial employers, what are you thinking in terms of how you are positioning eConsult in that market, in a large employer market?
Sure. Well, currently with our advanced payment models, we invite our large employers to participate in those advanced payment models. So moving forward, as we continue with our pilot and conduct our investigation, early analysis does show the value that eConsult is adding to all parties involved right now, the payer, the provider. So, we're looking at, do we include the eConsults in our advanced payment models in 2023, which would involve those large employer groups, and the opportunities for shared saving arrangements to benefit eConsults as we shift to the appropriate setting and hopefully lower the total cost of care for everybody.
Yeah, and I think we had one of our last work groups meetings, we had a whole session on engaging the patient. And, once we start hearing patients ask for an e-consult prior to a specialty visit, I think then we'll all be a huge win, and educating the large employers on that will be important. And back to you, John, with Aledade, I was really struck by two of your principles, I guess, one around accountability and the other around appropriateness. And those are two areas that I think, as we look at measuring the effectiveness of e-consult, it's always really difficult to be able to show, and what are those metrics, or how do you kind of engage and inform both the specialists as well as the system itself that this was an appropriate e-consult, and that we are holding both the PCP and the specialists accountable for that. And I'm wondering how you're thinking about that, and how does that kind of manifest itself in your work?
I think it's starting with the end in mind. So I don't have a particular answer or methodology at this moment, but I do anticipate in the future that in order for Aledade and ACOs to be ultimately successful, we have to marshal everyone in the community into some form of value-based agreements, whether that's actually in the ACO itself, or whether CMMI puts out a condition-based bundle instead of just a procedural bundle, or if Aledade and the ACOs themselves or direct contracting entities enter into their own specific agreements with different groups. But I feel like if we're not thinking holistically about the community in which our patients live and our primary care doctors practice and interface with the specialists, and think about the community being the accountable place, not just the primary care office, that we're not going to design a system that ultimately puts that web together. So there are global appropriateness measures. Each professional society has a whole lot of clinical practice guidelines that can be the starting points for discussions about appropriateness measures. But at the end of the day, it's also about the business case for the specialist. I think overall, my impression is that specialists are generally overwhelmed. So if primary care doctors can either be better resourced or more knowledgeable or more confident in their skills in handling some of the lower acuity things they delegate to specialists, like knee injections or something, then that will end up benefiting the specialist who earns the trust of that primary care doctor and actually sees more surgically appropriate patients in their clinic.
I think we've seen examples of that. I just saw Dr. Gibney chime in too, and really struck me about how they have their model where they have strong relationships with those specialists that are able to give those e-consults. And yep, Scott.
Yeah, can I just add one thought to that too? I think the notion of the relationship and the trust and the culture between primary care and specialty care is so critically important to having these models work at full effectiveness. We have a variety of mechanisms to sort of try to get the pulse of PCPs and specialists about the appropriateness of the exchanges that are happening. And our specialists always have the option of converting an e-consult into a referral or into a recommended referral if they feel it's truly not the right space for an e-consult. So I think, again, this notion that you've got to make a model that's easy enough for PCPs to be willing to use and incentivized such that PCPs see the logic in using it in their own crazy days, but at the same time, it gets the right information to the specialist and gives the specialist the autonomy to decide when they are comfortable answering the e-consult and not. And then you have to have a quality oversight process to make sure that no one's abusing either end of that process.
And I think in just the last minute here, another question came through, just a little bit more of the how is e-consult being incorporated into APM? Advanced payment models? Is it being pushed into a quality incentive, or we generally call it in pay for performance here in California, or other models? Anybody want to start there, just how you're thinking about it or seeing it being incorporated?
Yeah, real quickly, I think total cost of care models should inherently incent that. I was replying to Diana in the chat. Or actually, I replied to Lauren Jacobs only in a direct message, so apologies for that default listing. But in any event, I think it's the accountable care organization who should be interested and able to fund those over time. Support from the payers, as I acknowledged, from folks like Amanda, is certainly welcome, and I think is a win-win, no doubt. And there are other ways that payers and primary care doctors and specialists can collaborate to improve the delivery of the other programs that Amanda and her team purchase, thinking of digital point solutions and other bundle payment programs that we want the employers and customers want the increased uptake of. The other idea I've always had is just how can we expand from the knee arthroplasty bundle, which starts at the point of incision, to actually acknowledging and incentivizing the incredible cognitive decision-making of orthopedic surgeons to actually appropriately choose when to take a patient to surgery. So if and when those models come to bear, those would be natural interfaces for accountable care organizations, and really drive home this need for this consultation aspect between the two settings and incentivize it.
Scott, do you want to add there?
Well, and while I would agree that the incentive should be built in at the ACO level for the logic of using e-consults, it still requires the translation at the individual provider level to see that logic. And that's, I think, the concern. As long as physicians are compensated predominantly on a productivity basis, there has to be an incentive or a translation of that to them. In some primary care practices where they're moving more to a panel-based comp model, where the notion of the value of care you're providing and meeting quality metrics, that starts to translate in a different way to the primary care provider. But the other places we're talking about PMPM qualifiers potentially that are triggered with adoption and some level of use of e-consults at either an individual provider level or a practice level or a system level is another way of potentially incentivizing or finding ways to incentivize.
Well, I think we need to end there with looking at our timing, but I feel like we could have, next the chapter 2, which maybe we welcome as one of our next monthly work group calls, because we really do need to unpack how what we think is intuitive in being incorporated into models that we know is it isn't. So how do we start making sure that e-consult is up front and center? I thank all 3 of you, and we keep moving forward and onward. I'm going to hand it off to Libby.
Thank you, Timmy, and all of our panelists. That was great. I was taking notes frantically. You are all such a wealth of knowledge, and thanks for your involvement in our work group. Moving on to our panel on innovation. Speaking of people who've been involved in our work group for many years now, as I look at all of your photos here and your faces are popping up on our screen here, I want to thank these innovators who have really shared their learnings, their leadership, and their innovation with our work group over the past 6 years. So today we're going to hear from Brooke Levasseur, CEO of Arista MD, Dr. Darren Anderson, President of ConfirmEd, Dr. Stan Frencher, who is CEO of HumMD and also Whatwise Healthcare. We have Gil Addo, who is CEO and co-founder of Rubicon MD, and Chris Cruttenden, who is co-founder of SafetyNet Connect. We all know, after having listened to many hours of presentations today and over the past few years, that we know how e-consult works. So I've asked our technology innovators and leaders here to talk about how things are changing, how things are moving toward the future, how e-consult can change the lives of patients and improve their lives. So we're going to start with Brooke, and I'll let you go ahead. Brooke, thank you so much for joining us.
Thanks so much, Libby. Appreciate it. I'm excited to be here. Do you mind maybe going to the next slide? You can start with the placeholder. Thanks. So I'm excited. I thought I would take 10 minutes to share with everybody some data and some stories about how we've been leveraging one particular unique service to get our partners the maximum benefits out of the e-consult programs that we're launching with them. So at Arista, we offer a web-based technology platform to conduct e-consults. You can seamlessly transmit, lab notes, clinicals, images, anything patient specific that a specialist would need to see. And then we route those cases to our on-call panel of contracted specialists. And the technology is definitely important. That's why we've invested a lot in our integration capabilities. We offer a bunch of different EHR integration options, everything from SSO to a full integrated experience where you're doing everything within the EHR, and we can even auto-populate the entire e-consult request with basically a push of a button. We're doing all of this with the goal of delivering a more user-friendly and efficient system. But we found that the technology alone is not enough to realize the full potential of e-consults. And so what we've done on top of this technology platform is we've wrapped around it a service component, and that's what I wanted to talk about today. So this offering is called our Referral Nurse Navigation Service, or RNN for short. And this is an offering that we bring to clinics that support the program with a team of nurses who get virtual logons to the EHR in the clinic, and they will act as an extension of the local back office staff or referral staff. And the way it works is that we basically train our primary care providers that if they're working up a patient and they are considering a referral, think that it would be helpful to have a specialist weigh in, they'll just tell the patient, look, I would like to consult with a specialist. If this is eligible for an e-consult and appropriate, then I will send it off and I'll get back to you tomorrow with some recommendations and we can talk through the care plan. If it's not eligible for an e-consult, then I'm going to order that referral and the staff will be in touch with you. So we kind of leave it open-ended, and that way, the providers can just keep one workflow regardless of whether something's going to go to e-consult or for a face-to-face visit. So that within their EHR, they will place a referral, and that referral will then go into a queue for immediate review from our team of nurses. And so what happens is every time a referral comes in, our nurses will look at it and they will quickly establish whether the case is appropriate for an e-consult. And if it is, they'll go ahead and they will submit an e-consult in our platform on behalf of the provider. What this delivers is more consistent utilization of e-consults for all of the appropriate cases. And it really gives us the ability to offer PCPs all the benefit of the e-consult program without any burden to them or to their office staff. The other thing is that now our nurses have been working with clinics since 2017, and they just hold an incredible wealth of information and best practices that we can take and then share with the stakeholders at any clinic, whether you're using the nurse service or not, to help optimize the workflow and to better deliver on all the benefits, which, as we all know, those include, better access, better patient outcomes, saving unnecessary costs, and obviously quality. Do you mind flipping to the next slide? So as everyone in this meeting knows, we're living with a significant specialist shortage, and we've got this growing aging population, many of whom have one or more chronic conditions. And so they have a lot of complex healthcare needs, which are putting more and more of a strain on the system, and in particular on being able to get timely access to specialty care. And so what this means for many patients is they're waiting for weeks and sometimes months to get the care that they need. And I don't have to tell you guys, you all know that for underserved populations, access can be even trickier and the wait list can be even longer. So one thing that our referral nurse navigators will do is that we work with clinics to routinely review the patient wait lists. We will sit down with the clinic and we will look at all ordered referrals to see which ones have not yet been fulfilled. And we can identify cases that might be aided by an e-consult. Because what we found is that about 90% of the time when you do an e-consult, you will get back information and often interim care planning instructions that can be extremely valuable when you have a patient who is sitting on a wait list and does have to be seen face-to-face, but just is not able to get in right away. Next slide, please. E-consults are also proven to have a huge impact on patients. I mean, the ability to access this expanded care through your PCP has a bunch of different benefits. Aside from receiving earlier care, which obviously leads to better patient outcomes and often the avoidance of things like unnecessary ED visits, it can also result in significant cost savings and avoiding unnecessary time off work, travel. I think many people have mentioned these benefits today. When it comes to measuring the impact of patients on things through metrics like CAP scores, there are very few interventions that can have a direct, really positive impact. But we know that e-consults can improve scores around metrics like STAR measure C22, getting appointments and care quickly, or C27, perception of care coordination. So when our nurses come into a clinic, there are numerous ways which we help to drive these patient benefits. Even enhancements to the overall service that we provide, such as in certain markets, we've gone out and created community handbooks for clinicians so that the care coordinators and the PCPs after any consult, when they're putting together a care plan, can have access to patient resources, local things like food banks and shelters, transportation services. We try and compile that and work with the team to make sure they're getting the most out of this whole experience for patients. The next slide, please. In order for e-consults to be a sustainable model of delivering care, it really has to work not only in improving access, but it has to improve the cost profile of how we deliver care. And so at Arista, we've got a couple different ways that we track cost savings. The biggest one is that after every e-consult, we have our PCPs tell us through the platform if that case actually avoided the need for a face-to-face referral. And so we've captured this data on thousands of e-consults that we've done over the last 6 years. And we know that with our panelists, in over 70 plus specialties, around 75% of e-consults do in fact empower the PCPs to treat the patient immediately without the need for a referral. And this is important because we know that every referral has lots of varied costs that can really add up. And now we're talking about healthcare utilization costs, not just the patient associated costs that are also saved. Our nurse and our client experience team, we work closely with our clinics to really dive into the referral data and to map out and to quantify the various buckets of costs that we can shift. And we customize all of our reporting so that you have a real-time dashboard to see how we are achieving those cost savings. Just a quick glimpse of some real data we tracked this year with one of our clients who is at risk for the healthcare costs of their population. We worked with them in detail to go through and establish what are the actual costs associated with a referral to a specialist and to bucket all of the downstream costs. And that analysis yielded the takeaway that every e-consult we're delivering through their platform is saving them $815. So with that kind of savings, we really want to make sure that our partners are getting the highest ROI possible. And utilization of this RNN service has been really important to drive appropriate adoption to get the ROI. And I've sort of alluded to this, but the first goal of our RNNs when we work with the clinic is to reduce all of the burden on the providers and the back office staff. The other goal is to share our best practices and to help standardize the way that referrals and e-consults are processed at a site. So we will work to establish really clear criteria and rules for what is and what is not appropriate for an e-consult. And then we can set up corresponding workflows that take all of the guesswork out of that triage process. Our nurses are really effective in acting as an extension of the local referral team because they're able to, through our platform, leverage around 400 condition-specific checklists that we have developed, which very clearly specify which clinical notes, which labs, and which images would be helpful to include for each e-consult. So this ensures there's minimal, if no, back and forth between the PCP and specialist, and that the consulting physician is getting the information they need on the first submission. We also, through our nurses, facilitate messaging, notifications, and even delivery of the e-consult directly into the EHR for our PCPs. Again, we want to reduce any time and any work burden on the clinic so that they can focus on care and not administrative tasks. Next slide, please. Oh, and I will mention, sorry, I want to mention this because it's important. You know, this really works. The nurse service has shown in our client base to increase utilization of e-consults by 7 or 8 times over clinics who decide to curate themselves. We will regularly see clinicians at these sites who are submitting 30 to 50 e-consults for themselves a month. So that is a lot of cost savings, and that's why we try and get strong adoption. On the quality side, I'll say lastly, you know, we do have a meaningful impact on the quality of care and on the quality metrics that these provider groups are often held accountable for. And so when we launch with a site, we offer as part of this whole team solution to work hand in hand with the clinic quality leaders to evaluate all of the quality programs a site may be participating in to help identify the metrics that can be supported by e-consult. And we know that quality and risk management directors for organizations that, you know, have PCMH designation, for example, have said that we have been very instrumental using e-consults to meet the PCMH criteria and even to earn credits towards getting that designation. So no matter what type of programs our sites are participating in, our nurse team will work to ensure the adoption of e-consults will support these quality efforts and to demonstrate that the sites are making an investment in their strong financial stewardship. So with that, I guess next slide, please. I'll pass off the microphone. I'm looking at my time. I may have eaten up my time slot, so I don't know if there's time for questions. If not, you can always reach me, and that's my email on the screen. I'd be happy to talk about the nurse service or anything about, you know, our programs. But
Thanks so much, Brooke. What we're going to do is we're going to use the chat. If anyone has immediate questions for you, please do share them by the chat. And Brooke, if you don't mind staying on, we'll once we wrap up the presentations, we'll have some discussion at the end. So thanks so much for your time. And I'm going to hand it to Darren Anderson with ConfirmEd. Go ahead, Darren.
Thank you, Libby. Libby, I am so happy to be here, and I enjoy this conference every year, particularly when it was in places like San Diego or like Tahoe, but enjoying it today as well. I really want to thank you for the opportunity for us to participate and for pulling together such a great conference and doing it virtually, which I know is a challenge. This, in many ways, kind of feels like a reunion. I know almost everybody who's presented and everybody who's on the list, and I think it's exciting to be part of the e-consult community because it has and continues to be, in many ways, a small community. What I want to talk about today at ConfirmEd, just about everyone who chose a career in primary care did so, at least in part, because they value the opportunity to establish relationships with patients longitudinally over the long term, and to, I think, also relish the opportunity to help patients live their lives, create care plans that not only take into consideration medicine and diagnosis and science, but also the patient's lived experience, the patient's psychosocial history, the social determinants of health, and all the ways that those factors contribute to the way a patient experiences illness. And that's what we do best in primary care. And I was thinking as we've been presenting on the topic of innovation in e-consults, e-consults at its core is not a complicated technology. It's actually a way of communicating. And in many ways, it's a way of helping primary care providers to do what I just described and to do it better. I was thinking we refer people to specialists really for three main reasons. One of them is that they need some sort of a procedure, hands-on, something involving needles and scalpels, or things that we as primary care providers can't do. The second reason is the patient may have a really complex problem that needs ongoing management of a specialist, say end-stage congestive heart failure or something like that. But the third reason, and I think probably the most common reason, is we need cognitive input from a specialist. We need somebody with a little more expertise or experience to look at a case that we're helping to manage, give us advice and guidance, help us come up with a treatment plan, but hand that off to us. And that's really the space that e-consults exist. And we need to figure out the way to make that technologically as easy as possible so that those cognitive consults, the consults that don't require a procedure or ongoing management, the specialist can have access to as much information, all the data they need to render that cognitive input, but allowing the patient to stay with us in primary care. And so when we first started researching e-consults, we first sought to prove whether or not it actually worked and it was safe and effective. Then we sought to prove whether or not it was financially viable and made sense from payers. And I think that those two cases have largely been, have been entirely confirmed. Now the innovation that we need, and I think all of the presenters today have hit upon this, is we need to make this part of the routine process of providing primary care with minimal disruption. I thought it was really powerful hearing, I believe it was Dr. Miller, and actually several other speakers have touched on it as well, the recognition that primary care providers are busy. They've always been busy. They're going to continue to be busy. And anything that we do that adds more administrative tasks, makes the process of ordering a consult or receiving a consult more complicated, is only going to slow them down and is probably not going to be well received. So I think when we think about innovation and what I'm going to talk about today, the next frontier in innovation is not necessarily some big new technology as much as refinements in our process. In some ways, the way Brooke just described, we've been working very much in the same space, figuring out ways to make this as easy as possible for the primary care to utilize, so it just becomes the routine, normal part of primary care. So if I could have the next slide, I'm just going to emphasize a couple of things that we've been working on. I kind of feel almost like we give each other's presentations because I think all of us in this space are working on similar things. But essentially, what we're trying to do is to find ways to make that interface as easy as possible, recognizing that not every primary care provider is using Epic and is fully integrated with a large university system where they can one-click and e-consult. The practices that we work with, whether it's across the Central Valley or at Chapaday or Camarena or in Arkansas, are located in widely divergent locations, many of them very rural, have different technologies, and we've got to figure out a way to make that work. So if I could have the next slide. The main thing that we've been focusing on at ConfirmEd is expanded interoperability. And this means finding easy ways, complicated ways, simple ways of interacting with every health center and essentially meeting them where they are. Our philosophy has always been meet the clinic where they are and embed ourselves in the process with whatever submission. Every clinic in the country has some way of ordering a specialty care visit, and in most cases transmitting information about that case to the specialist. Fortunately or unfortunately, many practices, that's fax, e-fax out of the EHR. There's many other ways of doing it. Epic has a whole system called Epic Care Link. But essentially what we've done in our interoperability suite has given us a variety of different tools so that we can work with each clinic, whether we're directly interfacing with their referral management system, whether we're getting a seat on Epic Care Link and accessing the information similar to what Brooke just described, whether we're using Box to allow them to drag and drop images or information, or even giving them a fax number. All of those represent different queues of information, but they all come into our ConfirmEd system and result in the same thing, an e-consult that's put in front of one of our 220 specialists and a note that comes back into the primary care provider's EHR. And so what that means from the primary care provider's perspective is they order the consult in their EHR and they receive a consult note back in their EHR. We can't help the fact that, as was discussed earlier, the e-consult does often provide additional work for the primary care provider, workups that now they have to do. But if we can make at least the submission and the receipt process as easy as possible, we make the use of e-consults much more palatable and much easier to integrate into the process of ordering referrals and of caring for patients. That's critical because as a primary care provider, we are, as many other speakers have emphasized, we are located in our patients' communities. We speak their language. We have a team of people working around us in many cases to help meet not only their medical, but their psychosocial needs. And that's what we do best. And by making this part of the process simple, we can do that more often and reduce the number of times that patients actually need to see a specialist in person. And we need to relinquish that care to somebody else. Next slide, if I could. I think part of that also means that we have to think more broadly at the types of information that our specialists receive and the types of information that can help our specialists to render that cognitive input that we're seeking. We focused a lot on getting labs and getting notes, but if you think about it, most of the data and information that we do and have put in front of our specialist is provided by the PCP, which means we're relying 100% on the PCP to translate what they're hearing and seeing and capturing from the patient, and to present that to the specialist in one way or another. And that'll always be critical. But I think we also need to start thinking more about other types of information, ways that we can augment what we put in front of the specialist that don't just rely on the primary care provider. Image capture with smartphones, both photos and videos are one way of putting a new type of information in front of the specialist. We have a process where we can actually text a patient a link to a survey that they can complete. So if we want to get more information about their diet, for example, patients can actually click on images of different food types to indicate the types of food that they're eating that comes straight from the patient. So we don't need the primary care provider to give a detailed, comprehensive diet history for the patient. And I think taking that even one step further, thinking about other ways of collecting information directly from patients, like continuous glucose monitoring, home blood pressure cuffs, things like this. There's lots of information and lots of new ways of collecting information that can augment what the specialist can do without relying on the primary care provider to be the sole source of knowledge and information. Next slide, please. And then lastly, I think all of our primary care providers and our specialists will tell you that sometimes, even with the best of information relayed from the practice to the primary care provider or to the specialist, sometimes the specialist really needs or wants to talk to the patient. And we've heard several people talk and mention how nice it would be to be able to have that specialist talk directly to the patient, either in conjunction with the primary care provider visit, kind of a three-way visit, or even just setting up a live direct-to-patient telehealth visit. And we're incredibly excited to partner with CMD to build that capability into the ConfirmMed platform. And we've launched it in the state of Texas. We're going to be launching it in California within the next couple of months, so that we call it e-consult first. The e-consult will always be the preferred modality, and probably in 70% of the cases or so, the e-consult will be all that's necessary. But when the specialist or the PCP feel that really this is a case that needs a live discussion patient to provider, and in particular, when they feel that it would be great for the primary care provider to be able to be a part of that three-way conversation, we built the capability to allow that to be launched directly out of our platform and to integrate that seamlessly into the process. And we think that adds a whole nother ability for the specialist to get the information that they need and render that cognitive consult back to the primary care provider. They're not taking on ongoing treatment, but they're gathering additional information that helps them provide cognitive expertise that the PCP can now translate and manage over time with the patient. And so I think those are the comments that I wanted to leave you with. I'm excited to take questions after we complete the session. But thank you, Libby, and thank you everybody for allowing us to be part of this.
Thank you, Dr. Anderson. Super helpful to know how things are evolving. And I also want to thank our sponsors, our technology leaders, who are also clinicians. So Dr. Anderson, I really appreciate every time we turn around, there's a new publication around what you're doing in the clinic setting. We appreciate you sharing all that data that you're finding out there. And we're moving on now. I'd like to introduce Dr. Stan Frencher. I also want to thank Dr. Frencher for sharing these great findings and also sharing what's happening in different settings. So Dr. Frencher, I think you'll probably touch upon this, but recently you shared a publication on what's happening in correctional facilities with eConsult. So perhaps you will, I see you are going to talk about that. So I'll let you introduce yourself, and thanks for joining us today.
Yeah, no, thanks. Thank you so much for the opportunity. Again, it's also great to be on such an esteemed panel of folks who have been doing eConsult and involved in eConsult long before I knew it was a modality. I also have the pleasure and privilege of being able to present today from what inspired me to do this kind of work in the first place. My hometown of Detroit, near my grandmother's home, with my brother and father, both who are also physicians. And it impressed upon me why we're really here, right? I mean, we're really here ultimately to impact patients who are the least among us, oftentimes hardest hit during the pandemic, and often those who lack access. I'm a urologist by training. I practice 3 days a week, still operating twice a week in South LA. and that's where I was first introduced to the idea of e-consult. No one here needs to be convinced that e-consult is helpful. I think in terms of thinking of innovations, I think of it really from the sphere of a clinician, like, and both on the primary and specialty care side, thinking of ways in which we can do it and do more with it clinically, and also which patient populations have we not thought about and applying e-consults to. And I think correctional health, while it's something where others have I think thought about leveraging e-consult, I think it's reinforced more and more the more we work with our prison engaged, prison involved or justice involved patients. It really is a place that we found one can think innovatively about how much we can impact the lives of members of our community who end up there. For many of you who don't know, 1.2 million folks are incarcerated in state prisons annually. We work with and had the privilege of initially working with jails in the Inland Empire when we started. And as a result of some of the efforts there and some of the successes, we were asked to implement e-consult for the California Department of Corrections Rehabilitation. And I think in doing so, there's many lessons we learned in that process. And I think one of the most robust lessons is that context matters. So if there's anything you take from this presentation, it's that while all of us will talk about ways in which we have successfully implemented e-consult, the context in which we implement it matters. I practice in academic medical centers, I practice in county settings, and I grew up with a primary care doctor who had a private practice clinic. And what we see is very different depending on where we practice. And so when applying and implementing e-consult, at least our approach at Hub and at WISE, is to really go into the climate and environment with a community-based participatory research kind of hat. As a classically trained health services researcher and a clinical scholar, stakeholder engagement is also vital. So context matters, and I think stakeholder engagement matters. And I think we have an opportunity to innovate in both those spaces. We've already heard different implementation approaches, but we haven't really thought about what is the best approach depending on the client. And I think that's where, at least from our perspective, we're leaning towards, is trying to really understand and continue to build out the workflow engineering side of what we do. So I think that's the third piece. I think the third piece is you have to have innovative and robust approaches to implementing e-consult in each of these settings. It's not just about the incentives. I don't think it's just about reducing the burden on primary care doctors. While both of those are vital, I think it's about taking a holistic approach to the implementation of e-consult and understanding where the pain points are for those specific practices, those specific facilities, those specific systems, and how the specialty care is rendered in those areas currently. Contracted employed docs, county versus academic. And so I think that we have to be very mindful of the context in which we're practicing. And so, in terms of correctional facilities, we had to learn up on what are the important pieces when going to a correctional facility. Next slide. And I think what's important to understand is that you have to customize sometimes the services to match the need. And so ensuring that those correctional facilities that will work robustly on an EHR, then interoperability with that EHR is important. While other correctional facilities may not even have robust infrastructures from an EHR perspective and even struggle from a broadband perspective, depending on where they are. I think making sure that the specialists that you work with understand the context of practicing correctional health. It was new to many folks that there are specific formularies, ways in which folks practice on site, and a desire to understand how we can support them in ways other than the episodic e-consult. And so while I agree with Darren that there are those three forms of ways and opportunities to support our primary care colleagues in specialty care, I think the innovation is figuring out ways to also leverage e-consult in those other two spaces. So when we think about patients who are undergoing procedures, being able to provide insight and support both pre and post-operatively, being able to provide preoperative evaluations for patients by bringing specialists together in a multidisciplinary fashion. I think that the other piece on the innovation space where we're learning is that we've focused a lot on what is the benefit for the system and what is the benefit for the primary care doc and the patient. The benefit for the specialist is huge. My father, who I'm sitting with like here in Detroit, who's a primary care doctor, I asked him like, over 2 years ago to do telemedicine, wasn't involved in it, wasn't willing to do it, wanted to be in person with his patients and didn't see the value of an e-consult. He himself got sick and now is able to see patients through telemedicine from home and continue his practice in a way that wasn't even possible pre-pandemic. And so I think understanding ways in which for specialists, the asynchronous nature of e-consults enables us to serve an even broader population and at geographic distance. So I think while we move towards thinking about live e-consults and video visits, the reason e-consult is something that we found that our specialists, and now we have over 120 who support the primary care physicians in correctional facilities like throughout the state of California seen in this map, is because they can integrate it into their current practices. Like many of us are still practicing specialists. This is not our day job. And so I think we have to still be sensitive and mindful to how we can bring more specialists and more specialty expertise to doing e-consults by continuing to make it convenient in a way that's asynchronous and finding opportunities to make it synchronous in a scheduled fashion. And that is also work that I think many of the groups here on the panel are doing, both in trying to evolve their technology to support it, but more importantly, evolve a workflow that supports the clinicians on both sides of that live e-consult and the patients who are involved. And so for correctional facilities, you can imagine the benefit, right? So for many inmates, they cannot leave the facility without armed support that is highly costly. We've shown in our work that ultimately 65% of those e-consults submitted result in patients not needing to be seen face-to-face. For a correctional facility, that is enormous. And then in terms of the advice that happens when there is a face-to-face visit, really, that's where I think we can continue to evolve our understanding and our narrative that there is benefit even for e-consult when a patient is seen in person. And that benefit is improving the workflow, improving the workup, and improving the care coordination for that patient. And so I think we have to be mindful that while there may be an obvious ROI when patients are not seen through any consult process, delving into the details of the actual dialogues and dissecting what the benefits are for those who are in person, I believe is also the next step for us, thinking innovatively about how to evolve e-consult. And fortunately, I have a group of great researchers and students and fellows and a team that we now call Better, Building Equity Through Telehealth Endeavors and Research, who are now delving into the dialogues. And I think that is where we need to be when trying to figure out like where there is additional value from doing e-consult. Next slide. And so in summary, I mean, I think for us, correctional health and working with our justice involved members is super important. And I'll leave you with this story. I mean, I think that, I'm a urologist. Just a couple of weeks ago, I was taking care of a patient who had a urologic issue, a large stone that she had. She happened to, just by no fault of her own, get a lot of tickets and wasn't able to pay those, so ended up in the jail setting, like while waiting court, couldn't afford bail. Like she got a stent placed emergently, like by being able to leave and go off-site because she had a ton of pain for her stone. And that stent remained in place for her while she was in prison. She was released. She had no contact with her urologist who did it. It was difficult to figure out what to do next in managing that issue. She had the stent for 6 years. Her grandchildren didn't even know their grandmother without the stent in place. About 2 weeks ago, I took that stent out of her through multiple complex procedures, and she was so overjoyed. The issue is that even for those patients who may have to be seen in person and face-to-face, we have to evolve ways for us to support our primary care colleagues and our inmates. And I think e-consult can probably be a step in that direction. I want us to not forget at the end of the day that this is about patients' lives, and the patients who are impacted most and are most marginalized are often our underrepresented minority colleagues who happen to find themselves incarcerated. And I think we have to think of better ways to apply these tools to that population and spread it to other places where it doesn't exist. Thanks for your time. Happy to answer questions at the end. And thanks, Libby, for the invite.
Thank you so much, Stan. This has been really helpful to hear some of these firsthand examples. Yes, please do share questions for Dr. Frencher using the chat, and we'll have some time at the end to discuss together. And now I'm going to hand it to Gil Addo, CEO of Rubicon MD. Gil, it's been great to know you over the past few years, working out in California together. While we are bringing up your slides, and go ahead and show your face, Gil, if you're on with us. Wonderful. And I'll hand it off to you.
Awesome. Wait for the slides to come up here, but thank you. So first, thanks to Libby, Blue Path, and the entire work group here for the opportunity to share a little bit more in this forum. It's always wonderful to kind of bring together this group and see so many friendly faces as well. So my name's Gil Addo. I'm the co-founder and CEO of Rubicon MD. We are an 8-year-old digital health platform on a mission to democratize access to medical expertise. What I try to share out a little bit about is kind of why we got to do the work we do, and then I'll speak to what it is we do, and then we wanted to share a few stories from some of the experiences we've seen in other parts of the country. So first, the why. I got into this work because of some family and personal experience. I had a grandmother who was based in Barbados growing up. She developed a brain tumor. She traveled to Boston for surgery at one of the major academic medical centers, and then spent 5 years going back and forth on all the management of the tumor. And many people have heard this story in various settings, but the fundamental challenge is that the expertise needed to meet her needs just sat in these academic medical centers. And she sat thousands of miles away in a community that didn't have the same level of access. And so we built the business really, we had a mission around democratizing access to medical expertise before we even understood the product, and before we came to what the e-consult is. We really just saw this as a way to provide that expertise into a community that otherwise wouldn't have it. And that's what we built Rubicon MD around. Today, we support about 6,000 primary care clinicians across 37 states. We work in a handful of different settings. Primarily, we work with value-based primary care organizations. We also support community health centers that are powered and supported by other payers. And then we also work in employer on-site clinics with a number of Fortune 500 employers, as well as occupational health and groups across with other on-site facilities. And then we also support correctional health. So we're in 10 states at the state prison level, where we provide direct support to inmates through on-site clinics there as well. And then the fourth group is what we call direct primary care, which are primarily small practices that are in membership-based arrangements with their patients. What I want to share today is some of the stories that we've seen. We've built our business to really move to see ourselves as virtual specialty care, or what we call co-care plus. But how do you deploy specialists collaboratively into primary care to be able to support patients, not just with e-consults, but also with collaborative management across several specialties, and eventually being able to provide broader virtual care to through patients. Slide. Okay. So there are two case studies that we wanted to speak about. The first one, I'll just provide the context. CommuniCare is a set of community health centers based in Central Texas. They support a largely immigrant Hispanic population, and they basically are the primary, their primary payer is a group called Centene, or the Superior Health Plan in Texas, and they've funded the implementation of e-consults there. really focused around improving access for this low-income community. And all of their clinicians received access to Rubicon MD specialists. And we started working with them in 2017, really focused on being able to enhance access. For a population that's really hard to reach in a setting geographically, that's really hard to reach. The second one, which we'll go into, is called Callan Lord. Callan Lord is a set of community health centers based in New York that caters to the LGBTQ community here. They're based in New York, but they're widely recognized as one of the leaders across the country in transgender health. And so we set out to provide support around improving access specifically for the LGBTQ community. And this implementation, which we'll talk a little bit more about, actually resulted in a bi-directional partnership. And so Callan Lord was both the set of primary care practices that got access to the Rubicon MD platform. And then they were also a set of specialists that provided transgender health and support to other primary care practices across the country. And so it became a really, really valuable partnership for us because they got to see both sides of the interaction, and they were able to get value from the support of 130 specialties and subspecialties, but they were also able to provide out their expertise and understand from having been users exactly how to make that expertise most valuable and salient for their population. Next slide. So first, going into CommuniCare. For CommuniCare, we deployed it to about 100 to 126 clinicians across their centers. We went there, and the first rollout was in 2017 with a small subset, and then we steadily grew that, the total number of clinicians on the platform. They had full access to all specialties initially, and it was set up to be an implementation around that community. And so the neighboring community health centers also received access, such that patients who were tied to that plan, if they were to go to CommuniCare or to other centers, they would receive access to the eConsult platform. Some of the things that we saw: 76% year-over-year increase in platform utilization. And so there was incredible uptick of the platform tied to the ability to provide better integration from a workflow perspective for those clinicians. We saw 58% of the eConsult resulted in unnecessary services avoided. We measure this by asking the clinicians and the partners to provide us with an attestation of what happened after the eConsult. And we take that data and we can use it to quantify not just what's avoided, but the downstream financial impact. And so more than half of the eConsults avoided downstream services, which, we can come speak about that, but that's the real, impact in terms of patient satisfaction. And we saw that translated to $250,000 in avoided patient costs. And we think about that as the co-pays and the costs that the patients would have incurred directly had they had to go see a specialist. There's also the indirect cost, particularly in these communities. And you can see with the quote on the right here, it's so challenging for patients in this community to get to specialists. But in addition to that, they have to take time off from work. Particularly if you're hourly, that results in lost wages. They've got to travel, which results in them having to potentially expose themselves, particularly through COVID, to other, other risk factors. And then they've got to be able to make sure that they can actually make the appointment as well. And so there's a lot that goes into the patient cost savings that we were able to show, not just the direct cost savings, but the downstream savings as well. And then we looked at the avoided patient wait days and the downstream savings that we saw. And I think Brooke might have mentioned this as well, but the savings impact of e-consult, when you start to quantify the downstream cost, can be very meaningful. And so we quantified it as $650 in savings every time an e-consult was done, which has led to over $2 million in savings and reduction from avoided costs over the course of this partnership. And like I said, speaking to the actual impact within this community, it's really challenging to get to specialists. And one of the reasons that they first approached us was because they have network adequacy challenges in this area for a number of specialties. And so to have patients travel over 100 miles to see specialists just wasn't possible. And in most cases, patients just wouldn't do it. Next slide. And then as I talked about Callan Lord was unique because of the bidirectional relationship that we forged with them. So as a set of clinicians supporting the community in New York, it was 56 users. We saw, again, strong increases in utilization, 76% year-over-year increases. We also saw that about half the cases avoided unnecessary services. So the downstream impact was meaningful, and we saw very consistent, and we've seen this across all of our implementations, the avoidance of the downstream costs and the savings. We quantified the savings in patient dollars at about $60,000. And then the patient wait days avoided. This is quantified by looking at what is the typical time it would take for a patient to get in to see a specialist in that area. So it's 2 weeks for dermatology, and we're able to avoid that and get an opinion up front. We've saved 2 weeks in downstream wait days. And then the downstream impact of them serving also as our specialist panel. We've seen that it's been particularly powerful in correctional settings. So we've actually had their panel come and do custom CME and other webinars to help those who are managing incarcerated populations to manage some of the challenging conditions and specifically around hormone replacement therapy. And so it's been powerful in terms of their ability to advocate for the specific LGBTQ community's needs, but also to be able to bring this, the full force of our specialist network to bear for those populations. I think I'm being played off stage here. So thank you guys for the time, and we'll look forward to any questions.
Great. Thank you so much. We'll have some discussion time at the end. Please use the chat if you have any questions for Gil. And I'm going to hand to Chris Cruttenden with SafetyNet Connect. Chris, go ahead.
Okay, I can't do my video. I think you've stopped my video. Okay, there it goes. Fantastic. All right. First of all, thank you, Blue Path. This is a great event. Jumping to the next innovation curve for eConsult. Good afternoon, everyone. I wanted to thank ConfirmMed and HubMD for being great partners in our eConsult technology and pushing us to keep innovating our solutions. Our mission has always been to put health providers in the business of providing eConsult, and ConfirmMed and HubMD are great examples of the success of this model. I also want to share some exciting news, maybe not as exciting as Gil's news. Congratulations, and thank you for making the marketplace for this technology. SafetyNet Connect has surpassed its 2 millionth eConsult across all our clients, and have recently just launched our televideo platform, CMD, a televid solution that seamlessly works with eConsult and allows patients to have a virtual visit simultaneously with a physician, care coordinator, and or member of their care team. So you can actually have multiple people on the solution. All right. So patient shows up at the PCP's office and immediately is received by the doctor, much to the amazement of the patient. Doctor, I have some bad news and some really bad news. I just got your e-consult back from the specialist, and she said you have 24 hours to live. Patient shocked. 24 hours? That's terrible. Then what's the really bad news? I've been trying to reach you since yesterday. I'm sure people are laughing in the background. So the number of consumer digital apps ballooned last year with more than 90,000 new ones introduced in just 2020. The report found that there are more than 400,000 digital health apps available to consumers through app stores. Interestingly enough, though, according to app usage data, most of the healthcare apps have less than 10,000 downloads. So what is an innovation jump? A new idea, product, a process in an existing market? It's not new technology if it doesn't create efficiency, or a new process if it doesn't create value and improve outcomes. To use a cliche, it democratizes access and creates inherent value to the user, like Google's use case, access to data, Uber's case, access to transportation, Netflix, streaming content. E-consult by design has accomplished access, value, and efficiency. It is a disruptive technology, but overall adoption is far from market saturation, and non-mandated versions of e-consult, I believe, are less than successful. How do you innovate for a client that doesn't care about your service? Only when they're doesn't care about your service when they're healthy, or only use your technology when they're motivated by poor health. Even though e-consult in essence is a business-to-business based technology, its success depends on patient outcomes. These outcomes need to be tangible for a patient to recognize. Next slide, please. Patient impact. So everybody has this slide. I would say every panelist on the group can show the same evidence: reduced wait times, less travel, fewer days off work, more received and acculturated to medical, PCP more capable, better care coordination, specialists more informed on the face-to-face visit, fewer specialty visits, blah, blah, blah. Everybody has this. E-consult successful. Interestingly, these benefits that I list right here are actually quite amazing. In any one of these 400,000 apps, if they actually accomplished one of these benefits, would be successful. And we are accomplishing multiple benefits for the consumer directly. Patients are looking for innovation that helps save them time, educate them about their condition, the causes, and then allows them to actually take action based on the recommendation. E-consult needs to be designed in such a way that it would seamlessly include the patient in the dialogue or on their condition, next steps regarding diagnostics, and the treatment plan. Now, some physicians would push back and say patients can't handle that level of information, actually seeing the conversation between the PC and specialist, but it's already in motion. mHealth will be more personalized and direct to the patient in the next 5 years than it has been combined previously. It is happening, and it is moving forward, and patients are going to be connected. So e-consult needs to improve the relationship doctors have with their patients. It sets the stage that there is a team discussing their condition and figuring out the best course of treatment. We know when patients are aware of an e-consult being done on their behalf, they're less likely to miss their face-to-face visit. They're also more likely to do the required diagnostics necessary for that visit. Next slide, please. So creating an open standard system. This is just big ideas as far as I'm trying to just kind of push what we feel as a technology provider in e-consult. E-consult needs to have an open and agreed to standard in order to evolve. We need to create a US-based governing body to define the data standard in e-consult, a certification program that member participants can achieve, and an interoperability framework to allow seamless exchange of e-consults between disparate technology platforms. Now, I've heard a lot of great presentations today. It sounds like we're moving in that direction, not necessarily need to be prompted by me, but we do need this. I would love to be able to go and be certified as an e-consult group or system that does it the right way. We need to publish what we consider a successful model with key performance indicators that new adopters can follow. BluePath has been doing a great job of that, and which leads me to what I believe needs to be the next innovation, maybe not tomorrow, but in the future. Next slide. Virtual care exchange. An agnostic API-based eConsult exchange solution that can accept a standard eConsult from any partner organization. We could create a marketplace of specialists and specialties with support tools. Any partner organization could add their specialists or request specialists from another group across wide regions. This type of innovation would outpace Epic's iron grip on stifling integration and truly democratize access to specialty care. In conclusion, I believe now is the time for eConsult to jump to the next innovation curve. What I suggested might not necessarily be the next needed innovation, but eConsult has proven its effectiveness and is ready to be leveraged across larger and larger systems, across states, across the country. The presentations I've heard today make me optimistic about the future of eConsult. I'll leave you with this note from Western Union, an internal memo in 1876 summarizing the inability to recognize the coming innovation. Quote, "This telephone has too many shortcomings to be seriously considered as a means of communication. The device is inherently of no value to us," which is just amazing. They really missed the boat on that one. Anyway, I just want to thank everybody for letting me share what I believe innovation can be for eConsult. Thanks, Libby.
Thank you so much, Chris. And I'm going to bring everyone back on video for some Q&A here. And Chris, we apologize. We had a little ghost in our slide deck and it kept advancing. So we're sorry about that. We were jumping around a bit. Thanks everyone for coming back on screen. We have some questions coming in from the audience, and I have some questions myself for you all. So I'm going to start out with a question for Brooke, taking it back to your engagement of nurses into the eConsult facilitation and response. I think we all know here, I mean, you're either a technology innovator or you're a doer of eConsults if you're on this panel here. We all know the importance of the team, the primary care team, in facilitating the, the formation of the question and the gathering of information to send an eConsult. Brooke, how do you engage nurses, or what do you think differentiates the role of the nurse in this process?
Yeah, I think that it's about optimizing every stage of the workflow for the clinic. So it's not one size fits all, but what our nurses allow us to do is go in and do a little bit of discovery and learn what the current referral workflow and paradigm is, and how we can optimize not only the ordering process, but the criteria for how we triage cases to either in-person referrals being ordered or to go through an eConsult workflow. And then even the follow-up process, how do we optimize that by either working within the EHR or setting up standard alerts that go off, or leveraging our nurses to do notifications in the clinic. So it allows us a little more flexibility on the fly than just using technology out of the box, where just by definition, you're kind of set with whatever you're installing. And I think, everybody has talked about the provider shortage. It's obviously on the special side, but PCP side as well. Clinics are totally slammed and all sorts of activities are being shifted around. NPs and PAs are doing so much more. Back office staff is having to be leveraged for a lot of activities. So the fact that we have this this capability and this big team of nurses that we can plug in and not have to disrupt the valuable work that the teams are already doing is valuable, because you can just kind of hit the ground running and not have to bring in staff and tell them, okay, we're gonna have to figure out how to allocate time, et cetera.
Thanks so much, Brooke. We all know it's not just reliant upon the clinician or the MD to participate in the process, so thanks so much. I had a question for Darren, and it was interesting to see, sort of, as we focus so much on asynchronous communication between primary care providers and specialists, maybe you can help to differentiate, when is it going to be, when do you see the flag, or when is the cue to engage the patient in the process? Since our whole idea of eConsult is peer-to-peer communications, how do you see that transition from the peer-to-peer to the patient engaged communication?
I like to refer to it as an augmented e-consult, because at the end of the day, we are still providing a consult note back to a primary care provider that they're going to execute on. We're not talking about telehealth, where the specialist is just using telehealth as an alternate way of providing what likely will be ongoing care. And I think, kind of as Stan pointed out, it's an add-on that we have to treat as a very, very scarce resource. E-consults are scalable. Specialists, as Stan pointed out, can do it at the end of the day. They can batch them during the course of the day, and they can do large numbers of them. Whereas coordinating a live visit between a specialist and a primary care provider and a patient, or even just a specialist and a patient, is a much bigger lift. So I think my answer is it has to be used sparingly, and it has to be used. I mean, so our data, our data continues to show that about 70 to 80% of our consults that we receive don't require a face-to-face visit. They're completely resolved with the e-consult answer. But 20 to 30% do require a face-to-face visit. And in looking at those where it requires, it's not always because they need a needle or they need a procedure. Sometimes it's because it's a really complicated case. And for whatever reason, the data that we have in primary care wasn't sufficient to tease out some of the subtleties. So I think that I'll make up some numbers. Let's say 20% of the consults that we send back recommend the need for additional investigation. I would say probably about half of those might be able to still be resolved if the specialist could talk directly to the patient. So it's a small subset, but it's a subset where it's still possible to prevent an unnecessary trip to the specialist and all the details that everyone has talked about. And I think that's where this fits in. And the other aspect of it is many of our primary care providers will say, I'd love to take on the management of this case, and I appreciate the consult, but it would really be helpful if I could be part of that conversation. So I think it's a tool that can be really helpful. In a complex case, I was just reviewing one couple of hours ago, a case of adrenal cortical insufficiency, very detailed consult from endocrinologist, costintropin, stim tests, and multiple different things that needed to be done. That's a case where if the primary care provider, the patient, and the specialist could talk on a video conference, more almost like care management, they could probably resolve and decide what needs to be done and then implement a plan that the primary care provider can still implement in that primary care medical home environment.
Thanks, Darren. Super helpful. I'm seeing a couple of questions come in around corrections. So I'm going to pose this first to Stan, and Gil, you might also want to elaborate on this. So Stan, I think we've run into each other having conversations around corrections and utility of e-consult and corrections, and that all over the country, this is being embraced by correctional facility leadership for cost savings, for the ability to prevent patients from having to be moved. Maybe you could comment on how do you see e-consults helping the patient record move with the person who's incarcerated when they are transported from one facility to the next, or when they are no longer incarcerated? How does their record move with them?
So I think that where it comes together is a bit of what Chris mentioned and a bit of thinking about how e-consult fits in the context of the patients we're serving. So let me give you like the LA, like Southern California example. I mean, many of our prison, our justice involved like patients may start in the county system, may ultimately be Medicaid eligible patients, like, and they find themselves in corrections. And so I think that we have an opportunity, ideally, to create like e-consult relationships, like with facilities, like, and with the specialists that serve them, like to be able to not just have the information follow the patient, but to create structures that ultimately allow for the clinicians to share information across these like these settings in which we practice. If you take Chris's idea and move it forward, and e-consults all can be collectively aggregated in such a way that e-consult specialists, no matter who they happen to be working with from a vendor perspective or what facility they're in, maybe we begin to break down some of the silos that exist, even for someone like me who may see a patient in the county space, but do not have that information when I step 50 feet away into my private practice within the same community. So I think that, for correctional health patients, it's particularly important because they are going to return to our community. All of them will. And so if they're getting better care inside the prison than they're going to get on the outside, or vice versa, like we've already set them up for failure. And so e-consult may be an opportunity when combined with some of the technological, I think, blue sky ideas that Chris has. But it also requires us as an eConsult community to think how we can work collectively together rather than competing in areas that are already under-resourced. So those are my thoughts.
That's a great point, Stan, around how in many cases we may be figuring out more innovative and better ways to deliver care and corrections out of necessity. So maybe we can learn from those examples, since corrections is jumping on board here quickly. Gil, I know I know you also spoke about corrections, but I had a more specific question for you around specific patient populations and how we keep them in the medical home. And you brought up the LGBT community and ability to really hone in to their needs. And of course, this is becoming more and more apparent with transgender care. Maybe you can talk about how eConsults have been able to keep patients with their primary care provider in your cases.
Yes, I do think that for everybody here on the panel, and think everybody generally appreciates that having a relationship with a trusted provider is just incredibly important to ensuring high quality care. I think we talked about this, but like one of the lessons of COVID and the last couple of years is that people trust the person in their community. They trust the clinician that they have a relationship with. They trust somebody that's delivering culturally competent and appropriate care that understands the setting that they're in. They don't necessarily trust the physician on TV, or they don't trust whoever that person is that is coming from the outside to explain something to them. And so I think with everything that we've seen, I think it kind of reinforces the need to be able to arm those people who understand the context, who understand the community, who understand the patient best with the information. And so we've obviously for what we said around the breadth of our network, that's been one way that we've made sure that anytime you come to Rubicon MD with a question, it will be answered, so that that you can hold, if it's appropriate, you can kind of keep the patient in the community setting. But I think there's also the other side of your question, which is I don't think anybody here is advocating for holding back on appropriate escalations. I just think there's an appropriate use case for every modality. And so eConsult has a really appropriate use case. People think about it as text-based. A phone consultation has a really appropriate use case. Video has a really appropriate use case, and in-person has a really appropriate use case. I think when we evolve the healthcare system to be what it should be, that people will set, the appropriate volume, and the patients will be tied to those use cases. The same way we do some things now via video, we do some things on the phone call, and some things we do in person. I think we all, are very much bought into that vision. So when something needs to be seen in person, we've seen actually as much, if not more, impact from being able to escalate things quickly, where you get the quick opinion and you determine that something needs to be done because this patient is in probably a worse situation than previously thought. So I think it helps in all cases, but it's not just, it's about keeping them in the community and arming that clinician, but it's also about getting the information to escalate when appropriate and necessary.
Thanks, Gil. So before I hand a question over to Chris, I just want to give a shout out to being able to be a urologist and doing eConsult with one hand while feeding a baby and doing a Zoom with the other hand. So way to go, Stan. So just a quick comment came in, or a question for Chris. You've done this for 10 years, right? I think I met you 10 or 11 years ago when starting the eConsult program. You were starting up in LA. So what do you think about just what you learned over the past decade in terms of what we need to transform this system to make it more streamlined, efficient, possible for everyone to participate? Ideas come up about, some sort of common credentialing, or more easily streamlined process to bring providers on board. Chris, can you just share just any general comments on where do we need to go? Where do we need to take this so it's easier to get providers to be able to participate?
Yeah, two things come to mind immediately, and this is probably the same for Rubicon and Arista, as well as Hub and ConfirmEd. Seamless integration. I mean, PCPs, we ask them to do so many more things now, not just the eConsult piece. And having to log in other systems or having just kind of an awkward SSO where you still have to then do another search for the patient and find the documents, all those pieces would be really nice, because not everybody has an assistant or a referral manager to tee these up, to pull that technology piece forward. And we're getting there. I've seen it with other groups as well as us. That piece is coming. I'd like it to come a little faster. The second one is actually eConsult's success is causing problems, and that is we have a lot of specialists now on 3 or 4 or 5 different systems, and that's a problem. They're getting alerts via text or via email, and they're trying to jockey and manage each group that's coming in, and that is kind of where I get to this standard. We would need a universal place where I could receive them if I was a specialist from Rubicon, from Arista. I sure, you know, market wise, that's probably a little hard to swallow, but at some point that's going to happen. I mean, we have these epic versions out there that are not very good, and we need to have a standard and a universal ability for specialists like Stan, who can participate in 3 or 4 different platforms with one platform. And we've been working on that. I'm sure other guys are working on that, but that is the next innovation that we have to do because of the success of eConsult. And it's great. It's good we're moving in these directions. Hopefully that kind of answered that.
Thank you so much, Chris. And we appreciate everybody's time thinking about where we're moving, where we're going forward to be able to help patients, improve patients' lives. It's exciting to see these solutions evolve. We welcome additional comments through chat and questions from our audience. We have to move on to our next panel, but for those who can stay on and answer questions via the Q&A, we appreciate it. So thank you again, Brooke, Chris, Gil, Stan, Darren. Really appreciate your time. And I'm going to hand it over to Timmy and bring on Delphine and Paul. All right, go ahead, Timmy.
Taking us home here. Thank you, and thank you for a great discussion. And I don't know if everybody saw in the chat, you know, we are really indebted to our clinical advisors, Dr. Buchert, who you heard from to kick us off this morning, Dr. Lisa Arfons, who wasn't able to join us today from the VA, but I kind of channeled her really great idea. We were talking about engaging the patient, that we should have little buttons for all of you and providers that says, you know, to the patient, ask me about an eConsult. I'm motivated by the discussion today, and we should just make that happen. So let's look forward to that in our inboxes soon. And I'm joined here today by our other 2 clinical advisors. We have Dr. Delphine Tuot from from Zuckerberg General Hospital, and also Dr. Paul Gibney from LA Department of Health Services. And we have asked them to think about and walk us through how the data that they are seeing out of their programs is really informing our work going forward, especially in the equity area. And we have also heard, and I'll let Delphine go through this as an introduction, but we heard this morning about the collaboration that's happening in the Central Valley. And also just another theme that's been pulled through, which is that, you know, it really needs to be grassroots and informed, but the community needs to be informed and really understanding the impact in order to really grow and scale a system. And we definitely have seen that happen in LA, where you've had over 1 million. That's probably a very stale number now of eConsults. And we're you know, growing the coalition in a community. So I'm going to hand it off to Delphine first. And then we'll go from there. Thank you.
Great. Thank you, Timmy. I will wait for my slides to come up. Excellent. Thank you again for the opportunity to present. As I think many of the other panelists have said today, Joining this annual meeting is always a highlight. Just to hear new experiences, new ideas, new innovations. It's just a great way to keep moving our community forward as we're trying to move and further democratize e-consults, to use a term that was just used in the prior presentations. Great, so thank you. So what I wanted to take a lens just in the next couple minutes to talk about before we do questions and answers is to think about e-consult in the translational pathway. So how do we get to e-consult to where it started, to where it's actually going to provide great population health, where we can start thinking about equity. And this is a diagram that I just borrowed from the University of Wisconsin from their CTSI, their Clinical and Translational Research Institute website. And I like it because it highlights from a research perspective, starting from T0, in this case, it's using basic science, but for us, really e-consult as a proof of concept. And then moving to T1, which is bench to bedside. So e-consult consistently implemented for one service and one program. So at the San Francisco General Hospital where I work, that was gastroenterology when we started. We were doing great. Then we moved to T2, which is really spreading to other clinical settings. So for us, that's e-consult completely embedded within one entire health system. And so being used as standard of care for everybody in our system. Then moving to T3, which is really bedside to community. And so I think of e-consult in this setting, sort of spreading to all these different systems across the United States, internationally as well. But now, and this is, I think, where we are, which I'll highlight in the next couple slides, but now where we need to move forward is how do we get to T4? How do we do translation to the population health setting, moving from single systems that are doing amazing work to county level, state level, sort of national level way of thinking and translation. Next slide, please. And so this slide, I try to update it every couple months when I hear about new programs, but this is probably still a little old. But I just like to show that we're really still in the T3, I think, phase of adoption. These are single health system or single center kind of groups that are doing e-consult. There are also other groups that are included here, but they're all sort of self-contained, if you will. Like one group of FQHCs doing e-consult, maybe with one or two vendors, or one group doing e-consult with a vendor plus their academic health center around. So they're all relatively constrained within one academics or within one health system or one group of systems. Next slide, please. And within each of these systems, I think we have done amazing work, which has been highlighted throughout the day today. I think we have really shown that e-consult is in and itself can achieve the quadruple aim, right? We've improved the patient experience, we've improved the provider experience while there's still work to do to decrease the burden on primary care providers. At the population level within these individual health systems or group of vendors, we've reduced wait times for specialty care. We can escalate more quickly when triage is needed. There's better care coordination. There's a better safety profile. All of this has been shown for patients. And of course, this also has improved efficiency and lower costs. Next slide, please. I think where we now need to move is how do we show this on the population level, right? These advances may not translate equally across regions, particularly if there are smaller community practices and hospitals that don't have access to the vendor-based systems, don't have access to large academic health centers, and don't have access to specialists. And so this is where I'm really excited about the Central Valley e-consult Coalition, which you heard about earlier. It's an example of how we can move towards this regional level implementation of e-consult, really thinking at the population level. So the Central Valley e-consult Coalition, as you've heard about, is a regional work group with diverse referring providers, specialists, and multiple payers working together to increase the spread of e-consult in a geographic area. In this particular case, it's the Central Valley of California, which has many vulnerable populations, in particular, lots of low-income Hispanic populations, but diverse clearly as well. And the goal really is to spread eConsult and make it available to all of the populations in these counties, and to spread best practices with a goal that every single individual, adult or child, has equitable access to specialty care through an eConsult program. And you'll see at the bottom of this slide that the basic eConsult process is not different than what has been implemented elsewhere and what other people have presented today. I think the difference is the partnership among various payers, providers, vendors, so that we achieve this equitable distribution of eConsult to a community. Next slide, please. So together, the work group members are helping support eConsult use and availability across different payers. So supporting Medi-Cal and uninsured patients, as well as trying to spread best practices to private payers in the area. We have their monthly roundtables. We can provide provider support, education, and CME across different institutions and across different communities, because we can see what are the top eConsults from four different counties. And we can then leverage that information to really enhance the delivery of specialty care across the community. This group is also working together, of course, to inform and help support policy and reimbursement, and really sharing best practices. And then I wanted to highlight just the dashboard of provider adoption and how we can use a dashboard to start thinking about equity and population health. We're just starting, but I think this is really exciting. So next slide, please. So this group of dashboards, which are maintained by John Weir and his colleagues at Blue Path Health, so thank you, provide a snapshot of how the eConsult Coalition is progressing and growing. You see here on the left, so on the top, there's just a banner of total number of eConsults, just some run-of-the-mill statistics that we all use to look at how our eConsult programs are working. You can see here the number of eConsults by county. So there's one county that's particularly popular right now, but it's growing to these other counties because of shared best practices during these monthly roundtables. And this is the region that we really want to focus on. How do we provide equitable eConsult services and equitable specialty care across the region? You can see that the volume of eConsult services by month is going up, which is nice. And then we can see some basic eConsult outcomes on the bottom. I want to focus on the bottom left graph a little bit, which is specialty care demand. So next slide, please. And so this, I think we can use to see what are the greatest demand in this region. We can use this to develop targeted CME for providers across various IPAs, across various FQHCs. You can use this data to strengthen specialty care, primary care partnerships locally. So if we know that the top eConsult questions are for dermatology, say, can we try to strengthen the local partnerships between dermatology and referring providers when dermatologists exist? I think down the road, this is a little wishful thinking, but down the road, can we use this type of information to recruit specialists to this area, right? You're getting 1,000 eConsults per month, and they're all for these really important topics and really important patient care issues. We really need a dermatologist here or a rheumatologist here, as an example, right? And these types of data can be leveraged by the specialty care groups in the area, by payers, by academic medical centers in the area, again, to try to bring specialists locally to where it's needed for that escalation to in-person visits. Next slide, please. Importantly, we can start to track equity metrics at the population level. So here we can see eConsults by age, by gender, by preferred patient language on the right-hand side. And then on the bottom here, by ethnicity, by race ethnicity. Now, not shown here is how this compares to the actual demographic population of the counties themselves that are participating. And that's what we want to do next, so that we can better assess our progress of e-consult equity and making sure that all patients of all race, ethnicities, and all demographics have access to e-consult and specialty care equally. And also our goal is then to leverage this e-consult coalition and the introduction of e-consults in the county approach really as a natural experiment. So then we can look at county level health outcomes pre-implementation and post-implementation at the population level, really leveraging our key partnerships among all the providers and the payers. And my hope is that this rich county level data combined with patient stories and patient qualitative data can really push us or help us push the needle for reimbursement and helping policy leaders really acknowledge the importance of e-consult. So next slide, please. I think this is my final slide. Perfect. And really, so those data are just going to help close this loop and really push us to the translation of e-consult at the population level, which I really think is our next step and is a priority, I think, for 2022 and beyond. So I'll stop there.
Thank you, Delphine. And, I'm super excited to see where this goes. And I know that we're just starting with the dashboard, but we're starting somewhere and we'll continue to grow it over time. So I'll hand it back over to Dr. Gibney.
Thanks, Timmy. It's great to be with everyone today. I agree. I love seeing all the people and the participants and the growth of this. I'd like to add to the conversation on health disparities promoting equity. Next slide. I love the comment that Laura made in her keynote when she said, normal wasn't all that great to begin with. And it's really true. It goes to the heart of why we do e-consult. Because care as usual in America doesn't meet really anybody's needs optimally. And if you look at it from any perspective, the way we do medicine in America needs to be improved. We can go to the next slide. Because the problem is that the way I see it, the healthcare system as it's currently designed, it actually creates disparities. It conspires against equity. You can see the different categories that I've put on this slide. Insurance tells people where they can or cannot get specialty care, or what they can receive or what they can't receive, or how they go about receiving it. Obviously, we've highlighted geographical considerations. And it's not just rural areas, it's metropolitan areas as well. There's a lot of fragmentation in healthcare delivery, except for the big academic medical centers, tertiary and quaternary care medical centers. Most healthcare providers don't offer a full menu of services. And so patients are traveling all over a region to get the care they need. We've talked about transportation difficulties. We've talked about difficulties in getting time off work. Most providers in American medicine don't speak anything but English, and that also drives inequity. We've talked about timeliness as well. And one thing that we haven't talked a lot about, but I'll touch on today is that something that drives inequity and disparities is that both primary care providers and specialists are highly variable in the way they go about their clinical decision-making and the way they advise patients to take the next steps in care. And since I only have a few minutes today, I'm just going to focus on the areas that I've highlighted in blue. We can go to the next slide. And so I'm going to talk about fragmentation, provider decision-making, and overcoming geography. We can go to the next slide. And so in terms of addressing the concepts of fragmentation and geography, some specialty care services are rightly so only available in a few areas because they're so special. And because they might be low volume or really high cost, they need some really specific expertise. And so not every provider in a system needs to be able to offer that service, or not every hospital needs to offer that. Here in LA, a couple of examples are Kaiser Permanente, which is one of the largest healthcare providers in LA County, asks all of its LA County patients to go to their Hollywood Sunset location for radiation oncology. Because they've just decided they can do it more efficiently and effectively there, but people are coming to that place. Children's Hospital Los Angeles is one of the most highly respected children's hospitals in America. And so sometimes people come from all over the place just to get care at that one place. In our very large health system, which Timmy, to update you, we've done over 1.5 million e-consults now. We've got 4 hospitals. We've got over 24 different clinics. We pull from a very large geography, but we've even decided to centralize some key services in particular areas. And so orthopedic oncology is only at one of our hospitals. We have a nationally known rehabilitation service hospital called Rancho Los Amigos, and they do things there that nobody else in the county does, whether it's a county system or not. Bariatric surgery is, a very specialized surgery. It has very strict protocols to make sure it gets good outcomes. And so we do that at only 2 of our 4 hospitals. Joint replacements, certain pediatric subspecialties that are very rarely used are also at single locations. And so, how do you go about ensuring that everybody in your population care has access to those services, even if they're not geographically close to those facilities? So we can go to the next slide. What we've done is we've ensured that everyone using our e-consult platform, which gets over 20,000 requests every month, has the same menu of specialty options, regardless of insurance type or lack of insurance, regardless if they are a patient who is being cared for within our county health system, or whether they're being seen by one of the FQHCs that use us for specialty services. All of our services are equally available using the same platform, the same specialty reviewers, the same list of services, the same response time expectations, everything, including the services that we provide to the jail and everybody else in our network. We can go to the next slide. To give you an example of how this plays out, this is 747 requests to our Rancho Los Amigos special physical therapy service. These are services that are offered nowhere else in our county, really, but especially not in our system. And the blue slide is those PCPs that requested it from our hospital clinics. The orange segment is our county-run community-based clinics. The gray pie piece is all of the community FQHC clinics, and then the little sliver of yellow is our jails. But as you can see, all of them were able to request this very specialized service, regardless of the fact that they may be located 40 or 50 miles away from our Rancho Los Amigos hospital. We can go to the next slide. As I mentioned, joint replacement is offered at only 2 locations in our system, and you can see that same distribution. All of these different places that are all looking to us for joint replacement services can get them in an equitable way. They use the same process. There's no special treatment of one location over another. We can go to the next slide. So how do you ensure that all the specialists, we have over 650 specialists responding to e-consults. So how do we ensure that they get consistent clinical recommendations? We have something that we have developed internally, bringing groups of our providers together, primary care doctors and specialists within a given specialty or specialties, and they create what we call expected practices. And these are agreed upon clinical guidance that all of the providers in our system dedicate themselves to follow, unless, of course, the clinical presentation is unique, or it's different, or it demands a different clinical approach. And so we put these on the landing pages, the welcome pages in e-consult for every specialty, and we post them on a widely available clinical care library. And so you may think, well, it's nice that all those people spent time working on those expected practices, but what if nobody reads them? Well, thankfully they do. We can go to the next slide. So as you can see in 2017, our expected practices were downloaded almost 40,000 times by the thousands and thousands of providers in our network. You can see that reached a peak of 45,000 downloads in 2019. Obviously, with all the clinical disruption of COVID last year, we saw a little bit of a fall back to the 2018 levels, but even that was still around 38,000 downloads. And so people are looking at these, they're reading them, they're going to them, and they are seeking that consistent, low variable guidance from our system and from our specialty groups. We can go to the next slide. We did a study. We actually reviewed 2,000 of the e-consults done by our services in 15 specialties. And what we did was we asked peers within that specialty to rate the e-consult quality of their peers. So a gastroenterologist would be looking at other gastroenterologist activity, a cardiologist the same way, a urologist, et cetera. And we looked at actually a lot of variables, and the study is referenced on the slide. But in this particular case, I wanted to share with you what we found in terms of consistency, in terms of specialty recommendations following our expected practices, and quality. And so in terms of consistencies, their peers rated them 68% of time, the specialist recommendations to the PCP were in complete adherence with the expected practice. And 88% of the time, it was complete or at least partial adherence. And then when you look at quality, we asked the raters to say whether or not they agreed with the clinical approach that was taken by their peer in their specialty. And 86% of the time, the peer rater completely agreed or agreed with the decision-making by their specialists and their colleagues. And so, what I wanted to point out is equity is more than just making a service available. It's making it available to everybody in a population, and it's also being equitable in the kinds of recommendations, the kind of clinical decision-making you're guiding people with. And I think that is something that when you have huge specialty panels is actually really important to focus on, because you need to be able to have the confidence that your specialists are delivering a consistent and high quality set of clinical recommendations to the PCPs. We can go to the next slide. And so that's kind of the summary in these areas that I wanted to share with you today. And I will pause there and allow for any questions or wrap up comments from Libby and Timmy.
Thank you. Thank you, Paul. Thank you, Delphine. And I think just, hearing both of these presentations, is there something that you each take away on how you see that one might be able to feed into the other or vice versa? And how you're thinking about this? I'll give it to both of you. Delphine?
Sure. I mean, I think LA just provides a great example of how one system is taking eConsult and just moving it to the next level, right? I mean, just for the examples of equity that were just provided and variation reduction, and how do you actually provide specialty expertise to a large population in an equitable manner? And I think, again, our next step is LA has done an amazing job. How do we move that to all of Southern California, right? Like, how do we move beyond LA County, right, and LA DHS, and just bring it to every individual across Southern California, regardless of insurance, regardless of geography, regardless of language. And I think it's a challenge because not everybody even has a primary care provider, right? Like eConsult was really predicated on a strong primary care base. And so I think we do all of this together systematically, but my hope is that we can leverage a lot of these learnings in how to translate to the population level.
Yeah, and in Delphine's presentation, I loved seeing all those different centers from all across Central California, which has loads of variability and large geographic distances. And some of those counties probably don't even have a rheumatologist within the county borders who practices, or whatever the specialty might be. And so, using that to not only democratize access to expertise, but democratize the process, right? With so many barriers, trying to figure out, I think to Chris Cruttenden's point earlier, is how do we make sure everybody has access to this kind of expertise, and how do we, how do all the specialists involved in this also are able to contribute their expertise in more uniform and seamless ways?
Well, I think that that's almost, I mean, what I'm hearing, I'm going to say it, is it's a call to action, which is what we had hoped to come out of today. Not only in California, being able to, start with LA and spread, being able to take what we're doing in the Central Valley and spread it. But I think, as across the country too, what we heard earlier in what's happening in New York and Manhattan, how to then just make eConsult part of the referral process, and have all payers across all business lines and the uninsured as well have access to it. Is that, I guess, with that call of action, which would you kind of prioritize as one of the first steps that we take? Putting you on the spot.
I think one of the key things we need to do is to figure out how to, mainstream this. If we're going to go to population health, like Delphine was talking about, we need to figure out how to break down the barriers that people put up. I was describing, so I went to Northwestern Medical School, and I was at an alumni board meeting, and I was talking with some of my colleagues about that, who in Chicago were all in these fee-for-service systems. And they just couldn't get their minds around. They're like, well, how am I going to get paid? And how am I going to make money? And who in the world would do this? And, and all of that. And I don't have a good answer of how to break that down. And in our panelist chat, my colleague and mentor, Hal Yee, also posed the question of, how do we get away from fee-for-service on